Organizing committee of the first state conference on pediatric nephrology and on behalf of the particular National Kidney Foundation. I invite all of you, all the stalwarts of nephrology, adult nephrology, pediatric nephrology, and all the pediatricians from all over the state. We are going to inaugurate the scientific session, and may I request few stalwarts like Professor R.K. Sharma onto the dais for inauguration. Professor R.K. Sharma. Professor K.L. Gupta. Professor Vivekanand Jha. Professor Ashwini Gupta. Professor Narayan Prasad. Dr. Jensen C, who has all the way has come from United Kingdom. Welcome, Jensen. Dr. Sasi Kumar for further proceedings of the scientific program.
To all. So after so many fabulous days and sleepless nights, now we reach to a state where we can start our extravaganza academic fest. So we have divided this fest in 4 parts. And before starting, I request all the chairpersons and the speakers, since we have very close programs, please stick to your time. So as also instructed previously, so there will be a 20 minutes time for your talk and 5 to 10 minutes for discussion, just to ignite and keep our delegates in awake state. So we'll give much more emphasis on discussion. So 20 minutes for your talks and 5 to 10 minutes for your discussion. So we'll start our first session. I'll invite Dr. Madhu Sinha ma'am. She is Senior Consultant Pediatrician as well as Indian Academy of Pediatrician Bihar Chapter Secretary to conduct the first session. Madhu Sinha ma'am.
Good afternoon, everyone. And we are going to start our first session. But before we start, I want to thank Hemant sir and the whole organizing team for putting so much of effort to make it possible. And we are having the first state conference on pediatric nephrology. So that is a thing of pride for us, all of us. And so we want to thank them. And we are going to start the first session. And this pre-tea break session, all the sessions I am going to cover. And we are going to talk mainly about this nephrotic syndrome. So that is an entity you all would agree that all the pediatricians, they want to tackle and they want to treat the patients unless and until it gets complicated by something like frequent relapsing or steroid resistant. Then what we do, we start looking towards the pediatric nephrologist or the nephrologist per se. So today we have so many stalwarts who have come all the way from across the country to talk about all the aspects of nephrotic syndrome. But the opening batsman is from our state, and I want to welcome Dr. Jan Prakash sir to proceed to the dais to be the speaker. and he would be introduced by our chairpersons. The chairpersons for this session are very special because they are all our HODs, present HOD or the past HODs. So I welcome Dr. Vinod Kumar Singh, sir. He is ex-HOD, NMCH. Dr. Neelam Verma ma'am, ex-HOD, PMCH. Alka Singh ma'am, she is HOD, NMCH. And Dr. Avinash Sai, he is HOD, NSIT Beta. So I request all of you to proceed to the dais. I missed Dr. Bhupender Narayan sir. He is the chairperson for this speaker, and he is HOD at PMCH presently. So I welcome them all, and they would be introducing our speaker. We can have Q&A session. Yes, yes, sir.
For inviting us to chair the session. To begin with, we must express our gratitude from the side of IAP and pediatricians that this very academic bonanza has been arranged by our organizing chairman, Professor Hemant Kumar, and our organizing secretary, Dr. Om Kumar, and the whole team. You deserve a lot of appreciation and congratulations for that. And to introduce our speaker, Professor Jayant Prakash. He is professor and head of the department at IGIMS Patna. He has extraordinary talent in academics and clinical activities. It was fortunate that we worked together at NMCS for years together. And in one glance, many people considers him as my younger brother. You see the look is almost similar. And without wasting time, I must request Professor Jayant to begin the session. On this,
The subject is management of edematous child. Professor Jayant Prakash is very intelligent, has done his MBBS and MD from BHU. He has always been very good teacher and very good person. I just pray for success and start his talk on this subject. Thank you.
Thank you.
Thank you.
Sir. Hi.
Dr. Jayant Prakash is a good academician and इनका एक ही मोटो है, पठन पाठन ही इनका मोटो है. इसके सिवा इनका और कोई मोटो नहीं है और ये अपने काम को, इस कारवां को अपना आगे बढ़ा रहे हैं. थैंक यू.
Thank you, chairpersons, ladies and gentlemen. Right at the outset, I'll first thank the organizers for, entrusting me with this curtain raiser. So let's hope that the extravaganza begins on a positive note. So managing an edematous child, let us come to the brass tacks. Definition, whenever we are in any confusion, go for the definition. Edema is the abnormal collection of excess fluid in the interstitial space, and this leads to the tissue swelling, which we see clinically. The causes of edema is protein. We are all, you can clinically divide into generalized, localized groups. Generalized, we know very well: cardiac, renal causes, hepatic, various causes of hypoalbuminemia. But let us, go through the localized causes. Go for a history. If it is congenital, then it could be due to lymphatic anomalies, which could be in the form of maldevelopment or dysfunction leading to lymphatic obstruction. And this could, we have seen this in cases of Milroy disease, Turner syndrome, Noonan syndrome, etc. Take the history, if there is fever, then abscess, colitis, etc. are the causes. But if there is no fever, not congenital, recurrent, severe edema, always look for angioedema. You cannot miss this because it can end up in a medical emergency. Otherwise, for localized edema, you need localized allergen exposure, and it could be due to one of these: sunbite, frostbite. This time, even in Patna, people had chilblains because of severe winter. insect bites, stings, plant-induced dermatitis, etc. It's well said that pathophysiology is the cornerstone on which diagnostic and treatment workup is built up. What we are seeing is a diagrammatic representation कहाँ पर हरकत होने वाली है, and that is, the microvascular capillaries and post-capillary venules. There the starting forces are acting. We have the two out, two outward forces flanking them, and the two inward absorptive forces which are there. So very simply, when does the hydrostatic pressure, capillary hydrostatic pressure increase? It increases when there is, as in cases of heart disease or even in nephrotic syndrome, when there is sodium and water retention. And this pushes out the fluid in this area. Similarly, there can be, pi is representing the oncotic pressure. If the oncotic pressure falls, then also there will be generalized edema or anasaka, and this oncotic pressure can fall in any case which is leading to hypoalbuminemia, such as, again, liver disease, hypoalbuminemia due to PM, hypoalbuminemia due to protein losing enteropathy, which we are encountering more and more. Rarer condition, but obviously then we are more fascinated with it. Coming to the third thing is that if we, increase the permeability of the whole area, increased capillary permeability, as in burns, sepsis, the inflammation is there and the fluid will leak. In localized, whenever there is an obstruction, if you obstruct the venous end, then also as in thrombosis, if you obstruct even the lymphatic channel, because normally what happens, that there is a net outward flow from the capillaries to the interstitial space, and this is collected by the lymphatics and dumped back into the venous system. So suppose we obstruct either the venous system or at the local level the lymphatics, which could be due to maldevelopment or even inflammation like filariasis, and there will be a collection of fluids. So with this, नहीं इसको हटाओ यार. We just pay respect to the equation, but remember that this equation is applicable across all semi-permeable membranes, whether they are biologic or non-biologic. So homing on to, the nephrology topics, there are two hypotheses for edema in nephrotic syndrome. Speaking in front of so many nephrologists, it seems more like I'm playing Antakshri. The words, you may be able to catch me off keys at times, but just enjoy the talk. So underfill, there is proteinuria leading to hypoalbuminemia and resultant decrease in the oncotic pressure, which subsequently causes activation of RAS, and there is secondary water and sodium retention. Most of the children, almost 50%, fall into this, edema phenotype. But remember that this is basically due to capillary hemodynamic alteration or disequilibrium. Till that disequilibrium exists, as in this case, whatever fluid is retained will not be retained inside a circulatory system, but it will escape and gather in the interstitial space. So this is something like a cycle. So you have to correct the hypoalbuminemia through whatever means to stop this disequilibrium. The stumbling blocks are, we have seen, everybody must have seen cases who present with volume overload. So where is this hypothesis leading to? Moreover, if you treat by spinolactone alone, which should suffice, but that does not produce the required results. Lastly, with MCNS in steroid-sensitive nephrotic syndromes, you usually see that after steroids addition, by the end of first week, the diuresis sets in. And proteinuria usually resolves by the end of second week. So obviously, something more is there. So there came another hypothesis, which is overfill. And here it is that there is a primary sodium retention, which is causing volume expansion. And they have honed in on, epithelial sodium channels, that this channel in the distal tubule is responsible for this, and this causes sodium reabsorption. But the problem is that everybody has seen patients coming in hypovolemia, and secondary amyloid. It's in fact this channel is also known as amyloid sensitive channel. When this is used as a sole diuretic, the results are anything but satisfactory. So with this, we jump on to clinical presentations. There's nothing much to tell, just that diaphoresis during feeding is an interesting thing. For an infant, active feeding is as stressful as climbing stairs. So they will sweat during feeding, and don't ignore this complaint. Regarding liver disease, failure, we all know how to pick it up. Protein-losing enteropathy, keep your mind open. It can be associated with inflammatory bowel diseases. It can be associated with celiac disease, which we are seeing more and more, and even giardiasis, our own, disease. Renal diseases, the only thing which I like to say is that when there is edema and minimal systemic complaints, always think of the commonest presentation, that could be MCNS. Otherwise, never ignore growth parameters. You may diagnose CKD after the report. Otherwise, this will be a good clinical way. Nothing new in this. The only thing interesting is why hepatic ascites occurs first, then legs to face. And here the pathophysiology is that the cirrhosis leads to fibrosis and obstruction of the liver circulation. And this is causing, obstruction, rise in hydrostatic pressure. So first ascites and lower extremity edema, then anywhere else. Clinical tips, it appears funny, but okay, let's go with it. We have divided into three parts, and based on percentage weight gain from the baseline. Mild cases, nothing is to be done. A very hit question with MBBS student is कि facial edema क्यों होता है? तो यहाँ पर ही बता दें कि it is because of loose tissue, and there is interstitial hydrostatic pressure which is lesser here than in other parts of the body. तो वही स्टार्लिंग भाई साहब के कारण यहाँ पर facial and periorbital edema आ सकता है. Otherwise, there is nothing new. With you all, severe edema is usually associated with marked hypoalbuminemia, which presents with, ascites, pleural effusion, or pulmonary edema. But here I'll take a deep breath and try to see the world from the patient's point of view. Anasaka itself is a very distressing situation for the patient. The young patient, the quality of life is severely impacted. There is pain and discomfort. In fact, it was the major self-identified problems amongst the children. And reduced and painful mobility, and because of impending skin breakdown or scrotal edema, labral edema, the simple day-to-day work is painful. So please keep in mind these things also. And there's significant psychological impact. They have depression, they have anxiety, they have sleep disorders even, which, in addition to ascites and pulmonary congestion. So they have a very poor sleep quality. So keep these things in mind. So nowadays the fashion is that, the stress is that you first try to identify the edema phenotype, whether it is underfill or overfill, and try to manage and tailor your treatment accordingly. So we know the features of hypovolemia. We know if there is abdominal pain. Remember, then this could be due to gut wall edema and ischemia, and don't underplay this complaint. Check for shock. You can very well encounter hypovolemic shock in grossly edematous patients. History for oliguria always helps. In lab parameters, in underfill, this is mostly, everybody knows, this is usually found in hypovolemia. And underfill is associated with very low serum albumin, while overfill, serum albumin is low, but usually above 2. So go for the pattern of findings, and the problem is that most of these parameters become useless because the patients come with prior IV fluid or diuretic therapy, and the parameters become haywire. Other modalities, point of care ultrasound can help you pick up, inferior vena cava feeling. And you can see the collapsibility or the diameter and guess for the underfill or overfill. Bioelectrical impedance analysis is there in academic places, mostly research, but it gives you a good estimate of total body volume. Allergies, we are there with it. Nothing to tell you except that wherever facial edema is present, despite your OPD overload, always check for annual involvement. If facial edema is there, there are chances that there could be an airway involvement and it could be a medical emergency. Turner, see the dorsum of foot, hand and feet with edema. There are some life-threatening causes, generalized we know, but in localized, again I'll emphasize that allergic reaction, angioedema with airway involvement has to be promptly treated. Even ACE inhibitor-induced edema, ACE inhibitors are, kininase inhibitors. So whenever you take it, there is a higher level of bradykinin leading to vasodilatation and all the sequences of edema. So localized causes of edema should not be ignored. Workup, initial workup always leads to a better management because you go for a specific workup. In liver diseases, as protein losing enteropathy is becoming more and more, in focus, stool levels of alpha-1 antitrypsin. This is a non-dietary protein. You will never ingest it from somewhere. Your liver will make it, and it is not susceptible to the proteolytic enzymes. So the level of alpha-1 antitrypsin will give you the hint of protein losing enteropathy. Angioedema, rarer, especially hereditary angioedema, you can go for complement level. Management is treat the primary, stabilize the hemodynamics and the cardiac output. Mild edema needs no diuretics, but please try to admit these cases. You're admitting it, but what I'll emphasize is that if patients come with skin infection, cellulitis, or impending breakdown, or with lots of discomfort in mobility, please admit them too. It's not only the sick, but the discomfort which has to be addressed. Treatment, diuresis sets in, especially in steroid sensitive. Within a week, proteinuria response by the second week. In OPD cases, don't restrict the sodium, but there's a nice time to pass on the message that fast food nahi de, they are loaded with sodium. Fluid restriction is done only when there is severe refractory edema and steroid resistance is there. Acute unstable cases, you can go for exercise limitation, otherwise let the child lead a normal life. So this is an algorithm picked up from Indian Society of Pediatric Nephrology, very popular with us. Hypovolemia, apart from normal saline 10 to 20 ml per kg, we can also use 5% albumin after 2-3 boluses if the things are not improving. 5% albumin over 30 to 60 minutes if there is especially hypotension. Later on you can give 20% albumin over 3 to 4 hours. Mild edema ho gaya. Moderate and severe edema, when there is more than 7%, start with oral diuretics, but they can be gut edema interfering with the bioavailability of furosemide. So we can, if it is not responding within 2 to 4 hours, shift over to IV so that we bypass the gut. If this is not responding adequately, that is 1 to 2% of weight loss per day, then you can, use the thiazide or thiazide-like diuretics, which will use that sequential nephron blockade to potentiate the action of furosemide. But even if this is resistant, then go for albumin, which will improve the delivery of furosemide, which is tightly bound to albumin in the thick ascending loop of Henle. So this is the workstation where we face off with the disease, and this is the area where the furosemide acts, and it acts on NKCC2, sodium potassium 2 chloride co-transport. I'm very happy to remember this in full form. This is the DCT where most of the thiazides act, but if you combine furosemide with metolazone, it has its effect also on the proximal convoluted tubules. So we are, catching the sodium on both flanks of furosemide activity, and at times there is compensatory reabsorption in the DCT. I mean, this will be checked by your metolazone. So, diuretic resistance is to be addressed and tackled. So, I have discussed this. Diuretic resistance, apart from what I have mentioned, they can be poor salt restriction, and this will increase the load of the diuretic, so you will not get good results. Hypoalbuminemia also causes problems, and that is why we are combining albumin infusion and furosemide. Similarly, metazolone, if given 30 minutes earlier, ऐसा कोई बहुत reports में नहीं है कि बड़ा effective है, लेकिन fashion अच्छा है, and it makes you look smart. कि give 30 minutes earlier than furosemide. Albumin, remember, when there is hypotension and hypovolemia, go for 5%, give it like you give blood on any, colloid product. But if it is no shock, then go for, 2 to 4 ml per minute वाला 20% दीजिए for next 3 to 4 hours. Side effects are known. So this is what happens. We are so happy, not exactly happy, but we are always ready to take up the challenges which have been done by my esteemed colleagues on the pediatricians. We admit, and the treatment was furosemide plus albumin plus metolazone, and so this is ethically correct also, and we have accomplished. The mission is achieved, but sometimes we, in overzealous activity, overshoot, and what has happened is that the poor child went into a dehydrated phase with his sunken eyeballs, and we had to give normal saline. It happens quite commonly. Okay. So apart from diuretics, if nothing is steroid resistance, severe edema, with compromised kidney function, go for ultrafiltration of kidney therapy, a replacement. ACE inhibitors, especially in steroid resistant, and they are hypoproteinuric, decrease the edema, and long-term factors are also playing. In any case, it will help in even reducing long-term proteinuria. Other agents of change, tolvaptan has hardly any trials in, it's an aquaretic, V2 are a antagonist, receptor antagonist, vasopressin block karta hai, but no attempt in children. Treatment basics for other diseases, we are always trying to catch that increased capillary hydrostatic pressure due to sodium and water retention, which could be secondary or primary, and we do it by these modalities, which is very common. Never forget the specific treatment. Remember your super specialist friends. Spironolactone and IV albumin is also good. So, coming to my resources, remember, it is all right not to do not require full knowledge of any subject to apply the solutions. You simply have to have a good super specialist friend, give the drugs, and whenever you are in problem, call them up. Thank you. I think I have ended on time, so I'll take this liberty, give some value to my silver and missing hairs, because all the chairpersons are very senior to me, except for Avinash. So I'll take 2 minutes to thank them personally, which I didn't do because of the discipline we showed in following the timeline, right? So, Madam Neelam Verma, ma'am, she's pretty senior to me, but I won't mention how senior. But let me tell you, we are very, I was very close to ma'am's husband. जब भी सर पिकअप करने आते थे PMCH में नीलम वर्मा मैम को, तो she used to be busy, but I used to entertain him a lot. And he has nice habits. We had many things to share. Coming to Vinod sir ने बोल ही दिया. हम लोग का एग्रेशन भी बड़ा सिमिलर रहता था, बट विथ टाइम सर वैसे ही रह गए, मेरा ठंडा हो गया. भूपेंद्र sir is like an, elder brother, and Avinash is like a younger one. So sorry, I just extended my time limit. Thank you.
So thank you, Dr. Jayant Prakash sir. Is there any question or comments from the audience?
हो गया, ठीक है.
I think there is no question. So I would like to finish this session. Yeah.
Natriuresis causing
Yes,
water immersion in the nephrotic
water
chamber.
immersion used to be tried in adults, but didn't find
Children,
much
because
support.
in Chandigarh, our nephrology team was, pediatrics.
In fact, sir, if you, I shared my talk in the souvenir. So water immersion is mentioned in one of the articles. So even it was news to me also. पढ़े तो जाने नहीं तो जानते भी नहीं थे. Thank you.
And probably in olden times, the water immersion has got some scientific basis behind it. It shuts down the ABP levels.
In adults.
And yes, it can produce diuresis in some people.
Exactly. Yeah. But we have nothing against the quacks. They have also done their service. And you remember my last message, you don't require full knowledge to apply the solutions. Okay? Thank you.
But I think this is not recommended for nephrotic syndrome in children.
No, not nowadays.
Yeah.
Not nowadays. The article Khalash and all, it is very easily available on the net, and you can read the current recommendation. Okay. Chale? Thank you, sir.
So thank you very much.
Thank you, Dr. Jain, for such a nice deliberation. Edema. Thank you.
Thank you, Jan sir, for being on time and sharing your knowledge so beautifully that hardly we had any questions. And we are thankful to our chairpersons who were, and that is to be covered by a person who has come from a place where we get Sandesh. So I am very sure that she is going to give very good Sandesh about nephrotic syndrome, because we have Dr. Sushmita Banerjee from Kolkata, and she is going to talk about spectrum of childhood nephrotic syndrome recent guidelines. And for that, to chair, we have Dr. Suraj Kumar Gupta, Senior Consultant Nephrologist at Medanta Hospital, Patna. Then we have Dr. Mukteshwar Rajak. He is Senior Consultant Nephrologist at Bokaro General Hospital. We have Dr. Sushil Pathak from our place. He is Assistant Professor at Nalanda Medical College. And we also have Dr. Anil Kumar from our place. He is HOD at Betia Medical College. So I request all the chairpersons to come to the dais and introduce the speaker so that we can proceed in the manner we did the previous session. So thank you.
Good afternoon, everybody. I am very much thankful to the organizing secretary, Hemant Kumar sir and Om Kumar sir for inviting me. And the scientific session is very fantastic and very meticulously is being organized. And now this is the second topic of this session, and topic is very, very interesting to the general physician, nephrologist, as well as the pediatrician. That is the spectrum of the nephrotic syndrome and the current guidelines. Now over to the speaker, Dr. Sushmita Banerjee, already introduced by Dr. Madhu, and over to Dr. Banerjee. Thank you.
Thank you. So I will start with a very big thank you to Dr. Hemant Kumar and the local organizing team. I think this is a really excellent idea of organizing this crosstalk between nephrologists and pediatricians. And we, the pediatric nephrologists here, are really thankful and happy to be here with you all. The local hospitality and arrangements have really been excellent till now. So I will start with my talk, which is describing to you the recent guidelines on pediatric nephrotic syndrome. So we all know that that nephrotic syndrome is one of the commonest chronic long-term relapsing diseases in children. And we also know that it particularly seems to affect children of Southeast Asian ancestry. before antibiotics and steroids came into use, there was a huge mortality due to this disease, which was usually associated with infections, with kidney failure, with thromboembolism, etc. However, these drugs have vastly improved the outcome of this condition, but they have also added to it the morbidity due to the toxicities of these drugs. So steroid-sensitive nephrotic syndrome has definitely become easier to treat. However, steroid-resistant nephrotic syndrome remains quite a problem because many children do not respond to immunosuppression and develop multiple complications, drug toxicities, and many of these children will develop end-stage renal disease and even have transplant recurrence. So in this talk today, I will only cover idiopathic childhood nephrotic syndrome, which usually encompasses, although we do not do biopsies in them, previous biopsies in such children have shown that most of these children have underlying minimal change disease, whereas a few will have FSGS or mesangial proliferative glomerulonephritis. And the majority of minimal change disease and even a few of mesangial proliferative and FSGS conditions will be responsive to steroids. I will not try today to cover this vast topic. I will leave out the congenital and infantile nephrotic syndrome. I will leave out supportive therapies, vaccinations, complications of nephrotic syndrome and their treatment, details of drugs and monitoring, and post-transplant recurrence. However, these are very, very vital parts of managing nephrotic syndrome and very well covered in these very detailed guidelines. So I would appeal to you all to go through the guidelines, and a summary of the guidelines is given in the brochure in your bags. What I will include is the specific management, the diagnosis, the definitions, and the monitoring of childhood nephrotic syndrome. And this in itself also is a huge, really a huge topic to cover. So in case I do not finish, again I ask you that the guidelines are open access, a summary is available to you, so please do go through the guidelines. I think the most important part of the talk is this slide and the next slide. Why do we need guidelines? So I think my most important task today is to convince you all to follow the guidelines. So we know that the majority of pediatric nephrotic syndrome is relatively easily treated compared to many other renal diseases. However, many of the effective drugs also carry a large amount of toxicity. We know that pediatric nephrotic syndrome in many children lasts for a long time, throughout their childhood often, and it affects their social activity, their psychological status, including their physical well-being. And we want to limit both the short-term and these long-term morbidities as well as possible. And there's a huge amount of data and evidence that looks at the treatment monitoring of these conditions. And we need to know how to balance the evidence so that we use the most effective medications that are also the least toxic. So this balance is extremely important. And we need people to trawl through these huge amounts of data. And this is what the guideline does for us. It has, all these guidelines that I will talk about have graded the evidence available, and the recommendation is based on evidence. So these are all evidence-based guidelines, and because of that, we need to follow these guidelines. The second reason why we should follow guidelines is to standardize care. Because we all know that our patients tend to sort of hop around and shop around from consultant to consultant. We need to give these patients a very standard message so that the patients themselves know that this is what is expected of the disease, this is what everybody is telling me. From the doctor's point of view also, when patients come to us having seen 3 other different people, it is easy to pick up and continue. It is also easy to refer patients, to talk about patients with other consultants. So I think because of all these reasons, we really need to follow guidelines. Do we treat children the same as adults? And again, the answer is no. Pediatric patients need specific guidelines for children. And the reason again is that the disease, nephrotic syndrome, is very different when it affects children compared to adults. In children, the majority are minimal change disease. We rarely do renal biopsies, and we start with standardized treatment according to our guidelines. Pediatric nephrotic syndrome is relatively easily treated with short courses of high-dose steroids compared to adults who usually need longer courses. The complications are different. Children more commonly present with infections and hypovolemia than adults. They have a long course, as I have already mentioned, and most importantly, randomized control trials have been available, which have led to standardized guidelines evolving right from the 1970s. And this is a little different compared to adults. If you look at the KDIGO guidelines for adult nephrotic syndrome, adult MCD, you will find that there are very few recommendations, and most of them are practice points. So there are relatively fewer RCTs in children compared to in adults compared to children, because the childhood nephrotic syndrome seems to be a little more of a homogenized group. So these are the new guidelines I will be talking about: the International Pediatric Nephrology Association guidelines, the Indian Society of Pediatric Nephrology guidelines that I think most of us follow, most of us pediatric nephrologists follow, and the KDIGO guidelines. And all these guidelines mention the method by which they have looked at previous evidence, graded the evidence, and provided the recommendations. So coming to the guidelines themselves, first the diagnostic criteria, I think you're all very aware of. The child usually presents with edema, with frothy urine. In idiopathic nephrotic syndrome, it is rare to find hypertension or hematuria. And the diagnosis is made by simple urine and blood test. The urine protein dipstick may be 3+ to 4+ for protein, and the protein creatinine ratio is more than 2 mg/mg of creatinine. This is on a spot urine sample, which is usually an early morning sample, early morning to exclude orthostatic or exercise-induced proteinuria. And nephrotic syndrome means that you have this nephrotic range proteinuria associated with hypoalbuminemia, albumin less than 3 grams per deciliter, with or without edema. The initial workup includes a thorough history, clinical examination, and investigations to not only diagnose the condition, but also exclude any atypical features which might suggest underlying pathologies, such as hematuria, rashes, family history, etc. We also want to detect complications, because many children will present with nephrotic syndrome complications, such as infections, such as severe edema, such as thromboembolic manifestations, etc. And if there is no suggestion of an underlying cause, we call it a presumed idiopathic nephrotic syndrome. And in such cases, we do not need to do an initial biopsy or genetic tests. So renal biopsy is indicated in pediatric nephrotic syndrome only if there are atypical features, if there is AKI which is not attributable to hypovolemia, if there is steroid resistance, or a late renal biopsy may be indicated during the course of treatment if the child has been on cyclosporin or tacrolimus for more than 2 to 3 years. Treatment of the first episode, and all the 3 guidelines agree that it should be with prednisolone given at a dose of 60 milligram per meter squared per day, initially for 4 to 6 weeks, followed by alternate day prednisolone 40 milligram per meter squared or 1.5 milligram per kg. This is every alternate day for another 4 to 6 weeks. And this is based on evidence that shows that whether you treat for 2 months or for longer, 3 months or more, or whether you treat for 3 months and for up to 5 to 7 months, the outcome is really no different. So therefore, looking at good RCTs with low bias, it seems the outcome does not differ with prolonging the treatment in the first episode beyond 3 months. And that is why this 2 to 3 month course has been suggested by all the guidelines. And it is also in order to reduce the potential side effects of corticosteroids. Dosing weight versus body surface area. In smaller children, body surface area calculations means that 15% extra of the dose of prednisolone may be given, and this may be more effective in reducing the number of frequent relapses later on. However, it is difficult in day-to-day practice to use body surface area, and so the guidelines suggest that weight, that is 2 milligram per kg initially and 1.5 milligram per kg every alternate day subsequently may also be used. Single or divided doses do not show any difference in outcome. However, there is a suggestion of a lower toxicity profile with a single morning dose. Now, once the child has been diagnosed, treatment has been started, it is really vital to teach the parents to monitor the urine protein and record, because most of the complications occur due to prolonged untreated relapses. So the idea is to monitor, pick up the relapses quickly, and ask them to come in if there is suggestion of a relapse or an infection or any other complication. Now, on treatment of the first episode of nephrotic syndrome, the child may go into complete remission, that is urine protein becomes nil or dipstick nil or trace for 3 consecutive early morning samples. And if this occurs within 4 to 6 weeks, it is termed as steroid sensitive nephrotic syndrome, and if complete remission does not occur within this time, it is called steroid resistant nephrotic syndrome. Steroid sensitive relapses are treated, are defined if there is again proteinuria occurring for 3 consecutive days, and it is treated again by short courses of steroids, which are again similar to the previous episode, 60 milligram per meter squared per day or 2 milligram per kg per day until complete remission, followed by alternate day therapy, 40 milligram per meter squared or 1.5 milligram per kg for 4 weeks. There is some suggestion that lower doses or lower duration of therapy in relapses may be as effective. However, these studies are still involving very small numbers, and therefore the guidelines have not changed based on these studies. Now, this is a very topical issue. Do we change or give children daily steroids during infection to avoid relapses? And the previous the older guidelines, KDIGO and ISPN, suggests that daily steroids should be given to prevent relapses. However, the current IPNA guidelines actually suggest otherwise. क्या हुआ? So actually suggest otherwise, and this is based on the latest PREGNOS study, which was adequately powered to look for the change in outcome. And the PREGNOS study showed that there was really no change in the number of frequent relapses if you gave this daily steroid therapy. However, the circumstances are different. Our patients are different. The PREGNOS study was in UK, whereas all the other studies which supported this daily therapy was in Southeast Asia. And therefore, this is still a ground of open debate, and I think many of us are still resorting to change to daily steroids during URTIs to try and prevent infection-associated relapses. Now, frequent relapsing nephrotic syndrome and steroid-dependent nephrotic syndrome, I won't read out these definitions because you have them in the handouts and there is very little time, but the diagnosis of frequent relapsing and steroid-dependent nephrotic syndrome is absolutely vital, because it is an indication that these patients need some maintenance therapy to reduce steroid toxicity and to prevent multiple relapses. And these are the multiple steroid toxicities that you know that many of the nephrotic children develop if they are having to have repeated steroid therapies. So the options for treatment of FRNS and SDNS are prolonged low-dose alternate day therapy, or if the child is becoming steroid toxic on this treatment or requiring high-dose steroids to maintain remission, then we go for the steroid-sparing agents. I think most of us pediatric nephrologists in this room like to follow the ISPN guidelines, which suggest that in steroids, when we are using steroid sparing agents, we would initially like to use the agents that have low toxicities. So we would like in milder steroid dependence, we would like to use levamisole or MMF, whereas in more severe steroid dependence, we may use MMF in higher doses or cyclophosphamide. And only patients who do not respond to this, we then go on to using the calcineurin inhibitors and subsequently rituximab. Again, I do not have the time to go through all the evidence that these guidelines are based on, but there are Cochrane meta-analysis and many studies that back up the recommendations given by these guidelines. So now coming to steroid-resistant nephrotic syndrome, again, it is lack of complete remission at 4 to 6 weeks, depending on which guideline you're going to follow. And the majority of steroid-resistant patients need a kidney biopsy, except if there is defined infection, malignancy, or a previous diagnosis of a monogenic syndrome in the family. So the kidney biopsy requires at least 20 glomeruli and involvement of the corticomedullary junction to definitely exclude the diagnosis of FSGS. Genetic testing is required, particularly if there are syndromic features, if there is familial SRNS, and if there is CNI resistance. So these are the particular conditions under which genetic testing is done, and Dr. Anil will talk a lot about genetic testing subsequently. Specific therapy for non-genetic SRNS, again, this is evidence-based, and cyclosporin, tacrolimus with RAS inhibitors are the drugs of choice with tapering of prednisolone. Cyclophosphamide, if CNIs are not available, costly, or causing toxicity. MMF, if there is low GFR, and rituximab, if none of the above have worked, or if there is a prolonged CNI requirement. So again, these are the evidence tables that provide support for the recommendations given. Algorithms are available in all the guidelines that I have spoken about, but we have to always remember that all these drugs carry multiple toxicities which need to be looked at. And the final issue is that many of our children will actually keep relapsing till late adolescence and sometimes even into adulthood. And gradually from the age of 14 to 16 years, we need to keep teaching children how to look after themselves, how to monitor themselves, so that as they become adults, they are able to take on a lot of self-care. And eventually we need to transfer care when the child is above 18 years old, and we need to organize this transfer in a smooth manner with our adult nephrology colleagues so that the children are well looked after even in adulthood. So in summary, there are excellent guidelines, very all-encompassing guidelines available, open access for you to look at. With steroid-sensitive nephrotic syndrome, there's a very high potential for cure. We need to use effective treatment, but we need to minimize the short-term and long-term adverse effects. With steroid-resistant nephrotic syndrome, there are newer diagnostic methods involving genetics. There are newer drugs being used. So a guideline-based specific treatment is recommended for these children. And these are patients, the ones that are unmasked are the patients who have gone through many years of nephrotic syndrome and are now doing well. So this is a lady who has her own child. She received cyclophosphamide in the pediatric age group. This is a young man who is now 18 and going to college. The last child is a child with steroid-resistant nephrotic syndrome who went through a very hard time, was on dialysis for many years, and has now, 5 years ago, received a kidney transplant from her mother. Luckily, the disease had not recurred and is now doing well. Thank you.
Thank you, ma'am, for your excellent deliberation. It was very informative, very comprehensive, and definitely we have added so many new things in our pre-existing knowledge about the treatment of the nephrotic syndromes. Any question and comment from the audience? Our co-chairperson, Dr. Patrick, will say something.
Thank you, ma'am, for your informative lecture. Although this is not part of your lecture, but some practical points I want to ask you. So I have three kind of patients which we normally see in our day-to-day practice. One patient is on nephrotic syndrome, on steroids, and developed fever. So what should be our steroid dose? The second set of patients are those who are on...
Can I go one by one?
Yeah, sure.
So a child who has fever, definitely treat the fever. He's already on immunosuppression or not?
Already, he is on immunosuppressive drugs.
So definitely, treatment of the infection and the fever, etc. If it's a very sick child, then we need to give stress dose of hydrocortisone and continue antibiotics. If it is something like varicella, we might consider discontinuing any secondary immunosuppression, like cyclosporin, MMF, etc. But stress dose, hydrocortisone, adequate treatment of the infection with antibacterials, etc., and stopping very aggressive or weaning any aggressive immunosuppression temporarily is what I would suggest.
Okay. So you want to give the stress dose of hydrocortisone?
Yes.
So my second set of patients, those patients who are nephrotic syndrome in remission, had infection and relapse. So what should we treat first? Should we treat infection first, or we start right from the first day?
On any treatment or not on any treatment at all?
Patient is in remission. He is not on any treatment.
Okay, so again, I think, practically, it depends on how sick this child is. If a child is extremely sick, and the child has had steroids in the recent past, then again, just start the stress dose and treat the infection. Once the child is stable, go on to the full dose.
And suppose after treatment,
sometimes if it's a very mild infection and you treat the mild infection alone, the relapse might get better. So it depends on how bad the child is.
And a pediatric patients with LRTI or some kind of infection, and during that evaluation he found to have nephrotic range proteinuria. So should we wait for infection to go, or should we start steroid?
We can wait for some time for the infection to come under control, but not too long. We don't want, if the child is already edematous, then we do not want to wait for very long.
Thank you, ma'am.
Actually, looking after pediatric patients is also easy, but could be very challenging also at times, especially as you mentioned, the frequently relapsing nephrotics or the steroid dependent or steroid resistant. Now there is a lot of, I think next talk probably would address, we have to reach a stage where in difficult patients who respond even if they are infrequent relapsers, not a problem. But by genetic analysis, if we can move in a direction that there is a targeted therapy available for difficult patients. So I think that is the way probably management
I think
would
Dr.
go.
Anil will speak in detail about that. But only about, steroid resistant also, only about 25 to 30% patients will have genetic abnormalities detected, and the rest of them we will have to treat with our CNIs and RAS inhibitors, etc. But that is it can be a very difficult. When we started work, when we started training and treating patients, CNIs were not, I think Dr. Srivastav will be able to say even in greater detail, CNIs were not so easily available, and all we had were these Mendoza protocols, huge doses of steroids and IV cyclophosphamide, etc., which made the children really toxic and didn't work that well actually. So since CNI, since these guidelines and CNI started being used even in steroid-resistant nephrotic syndrome, a large proportion, I think more than 50%, and according to the data, 50 to 70% of patients will respond to CNI plus RAS inhibitors, even the steroid resistance. So I think, in the sort of 20 years of my practice, I have seen a major change even in the treatment of steroid-resistant nephrotic syndrome for the better. And I'm sure the next 20 years will bring even better news for these patients.
So since this is a very important topic, we can take couple of questions.
RTI and developed swelling and 2+ proteinuria. So, but ultimately when the thing is getting corrected, she's getting okay. So should it be bothersome or not?
I think if they're getting swollen, I would treat them. But often they come with an infection with urine protein of 2+ for a few days, and then if they do not have edema, I sometimes say let's wait another few days and see. But if they are having edema, I think I would treat them, because otherwise sometimes it gets out of control. The infection also keeps increasing, they get hypovolemic, they need admission, etc.
Thank you.
Sushmita, thank you for that. Children with relapsing nephrotic syndrome, steroid sensitive. Once I had a child, I was calling Arpana. Arpana said, sir, why don't you lower the dose of steroid and also add MMF as a therapy? And this worked very well, addition of MMF, because the child was taking previously cyclosporin and other things. So I found that now child is on 180 milligram of MMF a day and 5 milligram of prednisolone. No relapse at all. So I just wanted to say my personal experience of using MMF because of the advice given by a renowned pediatric nephrologist.
So thank you, Dr. Georgie. I think just one or two points to make. One is that follow the pediatric guidelines for doses, because
we are already late running, so please.
I'm just concluding.
Doses for steroids are very different, but the pediatric doses are evidence-based. So I think follow the pediatric dosing schedules that are recommended in the guidelines, number one. Number two is, if they are having frequent relapses and steroid dependence, as Dr. Georgie mentioned, don't let them get steroid toxic. Start the maintenance therapy early.
Okay,
thank you, ma'am. Thank you.
Thank you, chairpersons. Thank you.
Thank you.
All the chairpersons and the speaker are requested to collect their memento and also to get a group photograph then. So our next speaker is Dr. Anil Basudevan from Bengaluru, and he is going to deliberate on molecular basis of nephrotic syndrome sensitive to resistant. And to chair the session, we have Dr. A.K. Jaswal, ex-HOD, Pediatrics PMCH, Dr. Sanjay D. Cruz, Professor and Head, Department of General Medicine, GMCH, Chandigarh, Dr. Alka Singh, HOD Pediatrics, NMCH, Dr. Mrityunjay Singh, Senior Consultant Nephrologist at AIMS Gaya, and Dr. Himadri Shankar, Consultant Nephrologist, Ashray Clinic, Bhagalpur. So the chairpersons are requested to introduce the speaker and proceed. Thank you.
First of all, I would like to thank the organizers for inviting me as chairperson in this first state conference of pediatric nephrology, and the theme being kidney and the child. We have a noted speaker for this session, Dr. Anil Vasudevan, and he'll be speaking on the molecular basis of steroid-sensitive and resistant nephrotic syndrome. His areas of special interest, he is professor and head Department of Pediatric Nephrology at St. John's Medical College Hospital, and adjunct professor, Division of Molecular Medicine, St. John's Research Institute, Bengaluru. And he has done a lot of work on this molecular basis. His area of special interest is genetics of kidney diseases, and has had several awards and recognitions. He is member of the editorial board, Asian Journal of Pediatric Nephrology, member task force on tubular disorders, Asian Society of Pediatric Nephrology, member of committee for competence-based syllabus in pediatric nephrology, member curriculum committee for postgraduates, member of PhD committee, JIPMER. So, and he has more than 50 publications in national and international journals and authored more than 20 chapters on various kidney diseases. And I'm sure this is going to be a very interesting session and we'll learn more about this subject.
Thank you, ma'am, for your kind introduction, and good afternoon to all. At the outset, I'd like to thank Professor Hemant Kumar and team for inviting me here, and in a unique interface between adult nephrologists, pediatric nephrologists, and pediatricians, trying to find a common path towards managing children with kidney diseases. And thank you, Rajiv, for I am aware that you were part of designing this program. So what I'm going to talk about is probably the most common kidney disease in children anyone treats, be it an adult nephrologist or a pediatric or a pediatrician. The most common kidney disease in children that you face in an OPD is a child with nephrotic syndrome, and needless to say, it's a very intriguing disease for all of us. So this is a review that was published way back in 1940 in NEGM by Bradley and Stanley Bradley, where they discuss about the origin of nephrotic syndrome. And they speculate whether it's an extrarenal cause or a renal sui generis, that is a primary kidney disease. And they conclude by saying that it is viewed as a discrete entity, and as such, it remains an unsolved riddle. Now, coming to 2023, how much we know of this riddle, how much we have solved this riddle, I'll be touching upon the various molecular mechanisms that have been implicated in the pathogenesis of nephrotic syndrome. And when I say that, it refers to the idiopathic nephrotic syndrome of childhood. Each of these components are chapters by itself with large amount of experimental, clinical, in vitro, in vivo data that are often confusing, often contradictory. So I'll be just giving a gist of these current status of the immune system, the circulating factors, the podocyte itself as a key player in the pathogenesis, and finally the genetics of nephrotic syndrome. So as Dr. Shushmita has said, the nephrotic syndrome is probably more prevalent in the South Asian as compared to the other populations. The hallmark of this disease is the remarkable sensitivity to oral prednisolone therapy, which especially in children, most of them do respond. However, the subsequent course, there is a large amount of inter-individual variability that is not predicted by the age, the demographics, the previous treatment, despite the fact that all the children receive the same diagnosis. The subsequent course is very variable, with more than 50% of them requiring steroids during the frequent relapses, or continue to remain on steroids to maintain remission. And of these, probably 1/3 of these children are very difficult to treat, in the sense that they require multiple immunosuppression. And nearly 1 in 10 to 1 in 3 continue to relapse in adulthood. The younger the child has an onset, more likely that it may relapse in the adulthood. That's what the data shows. But fortunately, despite this terminal course, less than 1% have kidney failure. And this is in contrast to the steroid-resistant nephrotic syndrome, which is a different beast by itself, where 50% of them progress to some form of chronic kidney disease in 5 years of the diagnosis. So over the years, what has been very clear is nephrotic syndrome being a kidney disease, to being a glomerular disease, to being a disease that involves the filtration barrier. Now we know that the specific cell that is targeted in this disease, and that's the podocyte, which is a very interesting cell because it's a terminally differentiated cell. It has a unique architecture in form of foot processes that interdigitates and forms the critical slit diaphragm, which is the main component of the filtration barrier. And what is well known in nephrotic syndrome in childhood, or the idiopathic nephrotic syndrome, is that all the children will have effacement of the foot process. Which is with the starting point being the derangement of actin skeleton. So now these two processes are reversible by medication, by using immunosuppression and other forms of therapy. It tends to become problematic when there is detachment of these cells from the JBM or death. And which is fortunately seen in only in a few subset, that is 10 to 15% of idiopathic nephrotic syndrome. So what causes all this remains in the realms of hypothesis and conjectures. So one of the first proposition was by Robert Solow way back in 1970 in his seminal article, where he proposed that idiopathic nephrotic syndrome is a kidney manifestation of a systemic T cell dysregulation. And this, he based it on 4 clinical observations, most of them indirect, right from remission with measles to remission induced by steroids and cyclophosphamide and its association with Hodgkin's disease. Publication of this hypothesis prompted subsequent numerous studies, both in humans and in animals, where they did show this thing to be quite prevalent, such as the transcriptome analysis or infusion of supernatants of these cultured cells from patients with MCNS-induced relapse in proteinuria in rats. While a lot of experimental evidence was provided to confirm that hypothesis of association of T-cell mediated pathogenesis in idiopathic nephrotic syndrome, the subsets of T-cells that were involved remains to be unclear. So the initial work was on a particular type of subset of T cells. As you are all aware, there are 4 subset of T cells, and these are all produced from the CD4 cells in the thymus, and the differentiation and proliferation into a particular phenotype depends on the cytokine exposure from the antigen presenting cells that are exposed to various antigenic stimuli and conditions. For example, the IL-2 IL-4 induces the formation of Th2 cells that are involved in cell-based immunity, immunity and humoral activation. IL-2 induces Th1 that are the IL-12 induces Th1 that is involved in cellular immunity, while Th2 is involved in allergic and humoral allergic responses and activation. And these cells secrete their own signature cytokines. Like in Th1, it is interferon gamma, whereas in Th2, it's IL-4 and IL-10. So the initial work focused on these 2 subsets, and they showed that there is a Th2 bias or there is an activation of the Th2 pathway, especially with the association of atopy and allergy with nephrotic syndrome. But subsequently, the role of T regulatory cells or the Treg started becoming more clear, especially with conditions such as IPEX syndrome, where there is a genetic mutation that causes a impairment of the T regulatory cells. Now, how this happens and what has been shown is that the T regulatory cells seems to be suppressed or low during the relapses in idiopathic nephrotic syndrome, and probably this because of this imbalance of the T regulatory as compared to the Th17 cells, there is probably amplification of the neutrophil induced oxidative pathways in these group of children. While but unfortunately, there has not been significant clinical translation of all these findings. It was very intuitive that, probably looking at these signatures of cytokines, we could, try to understand and target these group of children specifically based on the cytokine pattern. But unfortunately, the evidences have been not only very heterogeneous, but also quite contradictory. For example, there are cohorts in which interferon gamma was suppressed, TNF alpha was suppressed, but we have FONT trial where they have used anti-TNF alpha therapy as one of the therapy for management of these difficult nephrotic syndrome. So nothing much could be clinically gained from these understanding of the T-cell mediated pathogenesis of nephrotic syndrome. Although the Salob's hypothesis has dominated the literature for many decades, there were evidences that other components of immune system are also involved, such as the dysregulated immunoglobulin metabolism, association with Hodgkin's lymphoma derived from the B cell secondary to an EBV infection, but it was never paid much attention. Like T cells, B cells are also a heterogeneous group of cells. Briefly, they constitute either of memory cells or the plasma cells. The plasma cells are either short-lived, that is, they remain in circulation for a short period of time, or they are long-lived, where they go back into the bone marrow and continue to produce the antibody independent of the antigenic stimulation. So this importance of B cell in the pathogenesis came in the nephrotic syndrome came quite accidentally. And it was with the use of rituximab in a child who had ITP with nephrotic syndrome. So as you can see here, this child who was very young had multiple relapses despite using many of the immunosuppressive medications, and the clinician gave rituximab for his thrombocytopenia, not for these relapses. And they found quite surprisingly that after the use of rituximab, there was sustained remission of the nephrotic syndrome. So it was an accidental discovery that pitchforked this B cell, importance of B cell in the pathogenesis of nephrotic syndrome. Now the question is, how does B cell how is B cell involved in the pathogenesis of nephrotic syndrome? Again, here there are a lot of postulates and theories and experimental data which shows different mechanisms, just as with T cell, different mechanisms that can explain the involvement of B cell in the pathogenesis of nephrotic syndrome. One is probably by altering the T cell homeostasis, because they do express a lot of surface receptors such as HLA class 2. They also have the ability to secrete a lot of cytokine and inflammatory mediators such as TNF alpha, IL-6 and IL-17 that can influence the T cell activation. It can also probably be because of secretion of what is called an hyposialylated IgM, which actually inhibits the effect of steroids on T cell, keeping them active for much longer than what is required. And this may explain why some of those children with steroid sensitive who are genetic negative do not respond to steroids. In addition to this activation of the T cell pathway, there is also evidence that it could be through an antibody mediated mechanism. Now, nephrotic syndrome is generally not known as an autoimmune disease, but what has been shown in both adult and in children with idiopathic nephrotic syndrome is the presence of antibodies such as, and these antibodies are very specific to proteins that are expressed only in podocytes, such as anti-CD40 antibody, which has been identified in those adults with recurrence of kidney transplant, following kidney transplant, presence of anti-ubiquitous ligand protein in children with minimal change disease, and anti-nephrin antibody, again in children with minimal change disease. So it could also be an antibody-mediated disease. But again, these data in small subgroups of patients with nephrotic syndrome. But the fact that there are many other markers that has been identified in these group of children, such as soluble CD23, IL-21, B cell activating factor in adults with idiopathic nephrotic syndrome, all these are factors that activates B cell independent of these other mechanisms. So it seems like there is also an antibody independent mechanism that plays a role in the pathogenesis of nephrotic syndrome. Similarly, they have shown that IL-4 activated B cells can produce proteinuria in mice models. Again, as you can see here, a lot of data in different types of nephrotic syndrome in different contexts have shown various mechanisms. But it's very clear that B cell is indeed involved, but it could be probably different between children and adult. Because when they looked at the different types of B cells, they found that the total B cells and memory B cells are increased in children, whereas plasma blasts are increased in adults with idiopathic nephrotic syndrome. So just as with T cell mediated hypothesis, even here we do not have much of a clinical translation into having a newer therapies. The rituximab, as I said, was more of an accidental discovery, but exact way in which it acts and prevents relapses is clearly still to be delineated in nephrotic syndrome. So, we all know that immune dysregulation happens in nephrotic syndrome, but is there a trigger? Because many a times, most of the relapses, like around 60 to 70%, happen following a viral URI. Many of them are reported following vaccinations or allergic events. So clearly there is a trigger that causes the uptick of this immune system. More recently, the French cohort in their population of nephrotic syndrome with relapses and first episode, what they did identify was that the EBV DNA was much higher in those who had relapses as compared to the controls. And they put forward this interesting EBV hypothesis where they postulated that the antibody against one of the EBV antigen called the EBNA1 cross-reacts with the podocyte protein, the nature of which is unknown. Initially, we used to think that influenza and other viruses, but here is some of the documented evidence that it's probably an EBV virus that triggers these relapses and may be involved in the pathogenesis of nephrotic syndrome. So often now we also consider that podocytes are usually the target of the immune system, which is generally systemic in nature. The frustration of not finding a specific pathway or a specific molecule which we could nail down into the pathogenesis led to a group of researchers who had this controversial hypothesis that it is not the immune system, probably we are overplaying the immune system, but it is actually the podocyte that itself acts as a key player in the pathogenesis of nephrotic syndrome rather than just being a target. And this evidence came from a lipopolysaccharide induced experiments in mice, especially in SCID mice, the combined immunodeficiency mice, where they do not have any form of T cells or B cells. In them, this LPS injected, when they are injected LPS, it triggered proteinuria, suggesting that there is some non-immune mechanism, or the podocyte itself is playing like an immune player. And later on, they documented that toll-like receptors, inflammatory or cytokine receptors are seen on podocytes. And now there is a paradigm that is being considered is that podocyte is a part of the adaptive immunosystem and plays an active role by activating a lot of these immune pathways within the podocyte, and that results in podocyte injury. In addition, there are other non-immune factors that are secreted by podocyte, such as angiopoietin-like 4, which also can cause proteinuria. So, and another interesting hypothesis was by the Japanese group, which suggested a two-hit hypothesis, that again, where the podocyte is a central player rather than being a target, where the trigger could be a genetic, toxic, or immunological, that results in induction of CD80 on podocytes. And this results in transient proteinuria. But a second hit that prevents the clearance of the CD80, because the CTLA4, which is required for the clearance, is impaired. And this results in persistent activation of the CD80, resulting in persistent proteinuria. So all in all, this suggests that these evidence suggests that podocyte is just not a target, but also an active player amplifying these immunological signals and pathways and causing injury. So we tried to explore this pathway in our own cohort, where we took plasma from different groups of children, steroid-resistant, infrequent relapsers, frequent and steroid-dependent nephrotic syndrome. We took this plasma and exposed them on immortalized human podocyte cell line. And after the exposure, we did a transcriptomic analysis. And we could see that the gene signatures obtained from the podocyte are quite different. And a blinded classification yielded something similar. As you can see, they categorized itself without providing the clinical data. It's called an unsupervised hierarchical clustering, that it falls into SRNS, frequently relapsing and infrequently relapsing. When we looked at the specific pathways that are expressed by these podocytes, while there are non-immunological pathways that are different between SRNS and FRNS and IFRNS, we also observed a lot of immunological-like pathways that are activated in podocyte, again supporting the fact that probably podocyte itself has an active role in the pathogenesis of nephrotic syndrome. The second hypothesis that was put around, as you can see from this interesting case report, just around the Salob's hypothesis in early 70s, was of this report of recurrence of idiopathic nephrotic syndrome after transplantation. But this hypothesis was much earlier in 1950s, but not much attention was given. And this gentleman, Dr. Gentili, actually did this daring experiments which we cannot think of it now. He took plasma from infants with idiopathic nephrotic syndrome and injected it to healthy children and documented proteinuria. So assessing that it's probably a circulating factor. And thereafter, there were a lot of evidences that did suggest that probably a circulating factor could be the main cause of idiopathic nephrotic syndrome in children, such as transplacental transmission, serum from patients with post-transplant relapse inducing proteinuria in rats, and so on. However, that has been a holy grail in the identification of the circulating factor. There are a lot of actors in this field, many of which were validated again in small subgroups of children with and adults with nephrotic syndrome. Many of them are immune factors like CLC1, interleukin 13 and 18. Many of them are non-immunological circulating factors such as vasoactive proteinuric factor, hemopexin, and more recently, SUPAR. But none of these have been shown to be consistently associated with nephrotic syndrome. Neither inhibiting these molecules have shown to remit nephrotic syndrome, again providing disappointment in terms of translation of experimental evidence into actually converting that into some clinical benefit. So here again, we tried to look at the circulating factor, and this was during my training in the basic science in Montreal, when there was a child who came with recurrence following kidney transplantation. And at that time, TNF-alpha was being considered as one of the putative circulating factor. So what we did was we took plasma from this child and exposed them to the immortalized podocyte cell line. And you can see here the cell lines which were having a linear actin organization got destroyed. Then we treated these podocyte with anti-TNF alpha antibody and then exposed this podocyte to the plasma from the same patient. And as you can see, the injury was prevented, thereby attributing to the role of TNF alpha. And finally, based on this, we did give this child the TNF alpha adalimumab, and there was some amount of control in the proteinuria for a year or so. So one of the dramatic developments has been in the genetics. I will be not talking about the clinical aspects. I'm happy to take the questions because of lack of time. And I may take 1 or 2 minutes before the bell. You can extend the bell by 1 or 2 minutes. It reminds me of the school break. One of the dramatic developments in the pathogenesis and understanding of nephrotic syndrome has been the genetics, especially in steroid-resistant nephrotic syndrome. And it pitchforked not only genetic, it pitchforked the podocyte biology into the central theme of pathogenesis of nephrotic syndrome. And it started with the discovery of the first genetic variant in the NPHS1 by Corey Antinac's group in France. Subsequently, a lot of attention was, and you know that nephrin is in the slit diaphragm, a lot of attention was paid to discover more and more of these genes that regulate the proteins in the slit diaphragm, like as in podocin and so on. But now we have discovered so many genes that not only regulate the structure, but also the function of the podocyte in general, such as a nucleus, mitochondria, in the actin cytoskeleton, and so on. So now we have more than 90 known single genes, but all these 90 genes probably explains 1/3 of the steroid-resistant nephrotic syndrome. So, which means that 70% of those steroid-resistant nephrotic syndrome, we do not have a clear etiology. It could be a circulating factor, immune dysfunction, or a gene that is yet to be discovered. But what it did help, unlike the immune pathway and hypothesis, it did help in the management of these patients. It not only helped in confirming a diagnosis, but it also in modifying our immunosuppressive therapy, in prognosis, and also at the time of transplantation in predicting recurrence, in identifying a suitable donor, especially if it's an autosomal dominant variant. And more recently, there is a nice study that has looked at particular gene variant in the CoQ pathway. And for the first time, a genetic variant is amenable to therapy. That is, by CoQ supplementation, they did observe, especially the CoQ2 and 8 are amenable to CoQ supplementation. Similarly, the gene called tubin is amenable to vitamin B12 therapy. Although strictly not a podocyte gene, it is expressed also in the tubular cells, they were amenable to therapy. Similarly, another gene called the ARGHDIA gene was amenable to eprenolone therapy. So we have now increasing evidence to say that some of the genetic mutations are amenable to medical therapy. And then which proportion of children have these genetic variants? This is the latest data from the Chinese, a large study, which multi-center study. As you can see, the proportion is highest in congenital and infantile nephrotic syndrome, and the blue squares are those with the genetic variants. And probably the least amount is found in the adolescent group, less than 10%. And there is no correlation between the histopathology and the probability of finding a genetic mutation. It could be either an MCD or FSGS. Similarly, while the most common genes that are found to be associated with mutation are podocin and nephrin and WT1 and PLC1, in our study of screening of more than 100 patients, we didn't find much of podocin or WT1, thereby attesting the importance of doing these kind of genetic studies in your own population. But when we did use in a NGS panel or a next generation sequencing panel, although a small number, we did find some prevalence of 30%. I mean, so the prevalence of overall genetic burden doesn't change, but the genes that are associated with steroid-resistant nephrotic syndrome are probably different between population. And Dr. Rajiv's study from Calcutta showed that COL4A4 genes, variants, are increasingly being associated with steroid-resistant nephrotic syndrome. While in steroid-sensitive, there is not much of data. There is only identification of susceptibility factor. This is the data from a meta-analysis involving various populations, including the South Asian population. And you do find not only HLA-DQ, but also non-immune hits, such as TNSF, NPHS1, as being a susceptibility area, which means that presence of these loci increases the risk of steroid-sensitive nephrotic syndrome. So the recent understanding has helped us caricature into 3 broad clinical groups of nephrotic syndrome, or the understanding. So one is that steroid sensitive are more likely to have immune dysfunction, and they tend to have a favorable course despite the number of relapses. Those with circulating factors are more likely to be late SRNS, rarely primary SRNS, where have variable response to CNI, and the proportion progresses to end-stage kidney disease and have recurrences post-transplant. Whether these are overlapping groups or 2 discrete entities are not very clear, because in our clinical practice, we do find that those who respond to steroid become late steroid resistant and have a subsequent poor course. So, but what is very clear is the primary defect in podocyte, the monogenic ones, which forms a distinct entity, and they are usually CNI resistant and have a family history of SRNS. So while our understanding has become better, but patients like these reminds us how less we know, and our treatment continues to be empirical. So this is a child who had an onset of nephrotic syndrome at 3 years of age. These orange bars indicates the number of relapses, not all I could include. And this is the proteinuria, the line graph. As you can see, despite the use of steroid-sparing agents, the child continued to remain steroid dependent, requiring long-term steroid therapy. As the child grew older, we were challenged with the biopsy showed minimal change disease. And as the child grew older, we had to face a lot of steroid-related side effects, right from cataract surgery to spine fractures and so on. This is a child which did not also respond to rituximab, but had developed hypogammaglobulinemia. When we biopsied this child after 14 years of the disease, we still found exactly the same picture as we found at the onset. A minimal change disease, and IF is completely negative. And this is a child, you can see a 17-year-old short with all the textbook complications of steroids, and reminds us that how less we know about this interesting disease. Thank you.
Really very mesmerizing and very exciting celebration on a very, very new subject. I think that is molecular basis. And just I wanted to ask you one thing, that can we see on the basis of this genetic basis on these genes, podocin and nephrin and other genes, can we see the future of gene therapy or CAR T-cell therapy? Oh, these two are new implication. Can we see the future in management of nephrotic syndrome?
So we are hopeful of having some form of therapy. These are all podocyte-specific genes, and targeting. The challenge with this is that podocyte is a terminally differentiated cell. It is not easy to transfect a terminally differentiated cell with a new gene, and that probably is the challenge that needs to be overcome before we say that gene therapy can be a realistic therapy in future. Unfortunately, the short answer is no for the near term.
What about this CAR T-cell therapy?
So it all depends on the etiology. So as I said, these monogenic mutations are in podocyte-specific genes. So unlikely that it'll work. The main issue is that it's an we have tried it in our own lab to transfect, and it becomes very difficult when it is differentiated completely. It's very easy to introduce the gene while it is proliferating, but not while it is
Thank you. I think any questions or our coaches?
Just a couple of comments I'd like to make. A wonderful talk. It was a pleasure listening to you. Genes and all these things which have come over the last 20 years have helped us in a way. As Professor R.K. Sharma said, you should not be over immunosuppressing your children or even adults. Some of the patients spill over into our situation, adult group also. So it helps us in stopping the immunosuppression and managing them conservatively. There is a family history, consanguinity, young age at onset, and if there are some phenotypical markers, then obviously there's a case to screen these people. If there is any questions from the audience, please raise your hand.
Thank you.
How much this genetic testing will cost to my patient, And third, how will it change the treatment of that patient?
Thank you for the question. I didn't put it here because of lack of time. So the indication for genetic testing is very specific. So if you have a CNI primary steroid resistant who is CNI resistant, that is one indication. Second is a family history of steroid resistant nephrotic syndrome. The third is an infantile or a congenital nephrotic syndrome. The fourth is a syndromic patient. So many of these nephrotic, a small proportion have syndromic, like Galloway-Mowat, Pearson syndrome, Nail-Patella syndrome. So if you have extrarenal features that suggest a particular syndrome, I think you should do a genetic test before treating them. And the last is at the time of transplant. It's a good idea to do this, and which will help us predict recurrence. And also in autosomal dominant form, it helps us choose a donor, because if the donor has the same variant, you may be hesitating in taking that donor for as a potential for the kidney transplant. So this is the indication. The management-wise, it helps in withdrawing immunosuppression. We are no longer aggressive in empirically changing the immunosuppression once we find that the variant is identified. It helps us prognosticate because 75% of them will land up in end-stage kidney disease within 10 years of diagnosis, those with a genetic form. It helps us predict the recurrence rate because that has less than 1% chance of a recurrence after. So in this way, and also of course in antenatal diagnosis and preventing a steroid-resistant nephrotic syndrome, these are the utility. The challenge is in getting a report, because most of the time it ends up as variant of unknown significance, and that becomes a real challenge. Sorry, the cost has come down very much. It's probably costing less than a PET or a MRI now. You can get this panel for 11,000 rupees to 13,000 rupees in commercial, and whole exome is around 15 to 18,000. So since there are no genotype-phenotype association, we can't predict unless it's syndromic. So we have to send a panel to identify the genetic etiology, and that will be the massively parallel sequencing or the NGS panel.
Okay, so nobody has any questions from the audience? Okay. No, he wants to ask.
Yeah, I can hear you.
So Anil, sorry. So is steroid sensitive nephrotic syndrome a genetic disease?
Right now, whatever the evidence suggests, it may be, I didn't bring it up because it leads to confusion. This is genetic susceptibility because around 5% can have a familial steroid-sensitive nephrotic syndrome. But there are few genes that may show some response to steroids, such as PLC1 variant. But they're doing a genetic testing doesn't help because anyway you're going to continue the management as in a steroid-sensitive nephrotic syndrome. So right now there is no indication for genetic testing, but a genetic basis definitely it seems like an environmental genetic and a kind of a paradigm in steroid-sensitive.
Okay, thank you, Dr. Vasudevan, for your very nice talk. And it was really interesting. It will decide the course of immunosuppressive therapy and in making new diagnostic tools and therapeutic effects. Thank you.
By Dr. Anil Vasudevan, but I think the things got a little bit heavy for the pediatricians, I feel. So we'll try to change your mood. And now we are going to hear something different. We'll have some case-based approach. And for that, we have someone who is difficult to bind to a particular locality, but still we take pride to say that he belongs to our state. So we welcome Dr. Narayan Prasad to come and talk about the case-based approach. And we are very glad to welcome you, sir. And for this session, we have chairpersons, Dr. N.P. Narayan, sir. He is ex-HOD Pediatrics, PMCH. Dr. Gopal Prasad, who is HOD and Associate Professor at Patna Medical College and Hospital in the Department of Nephrology. Then we have Dr. Birender Kumar Singh, Senior Consultant Pediatrician, and he is Assistant Professor at IGIC Patna and Pediatric Cardiologist. We have Dr. Anil Jaswal, who is Consultant Nephrologist at Asian Hospital, Patna. And we have Dr. Chandan Kumar, consultant nephrologist at Department of Nephrology, AIMS Patna. So all the chairpersons are requested to introduce our speaker, Dr. Narayan Prasad, and we are very glad to welcome you, sir.
Thank you, Dr. Madhu. Very good afternoon, all of the delegates. And it's a great initiative, and I thank Dr. Hemant and his team, Dr. Om and Dr. Amresh, who have made this possible. And this is a great initiative, especially if you account the state of Bihar and the, you see, quantum of pediatric nephrology cases. But it's quite unfortunate that we don't have that kind of super specialization right now, very much in practice right now. And sometimes it becomes very difficult for the nephrologists, I mean, who are really adult nephrologists and trained in adult nephrology, to tackle with these kind of pediatric nephrology cases. So I am sure that this is a great initiative. This is the first of its kind, and it's a very innovative idea, and I really congratulate the whole team. And today's speaker right now is Dr. Narayan Prasad, who is professor and head of Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And I appreciate that he is from state of Bihar.
I am from Patna Medical College only.
Yeah, that's right, that's right. I'm very, very thankful to you for that correction. Yes, that's right. And subject also is very lucrative for all the pediatricians, practicing pediatricians, who will find it sometimes difficult, you see. We are getting the steroid sensitive ones, which are in everyday's practice, but sometimes we are really stuck up with these kind of cases, which are difficult ones. And I think Dr. Narayan Prasad is going to address that issue. Sir, if you want.
Dr. Narayan doesn't need any introduction. He is son of soil, and I think his deliberation will enlighten us with such a difficult subject of nephrotic syndrome in children. We are getting our day-to-day practice nephrotic patients, and we face so many problems, and I think Dr. Narayan will enlighten us. Dr. Narayan.
At the outset, I would like to thank Professor Hemant Kumar, sir, and all the organizing team members, Professor Om Kumar, all the team of East Zone, who is organizing this great meeting. I always become nostalgic whenever I come back to Patna, so that is already there. And we all understand, we have not to speak on this slide because steroid sensitive nephrotic syndrome might have the different courses like infrequent relapser, frequent relapser, steroid dependent and resistant. And we all by this time know that complete remission can be achieved in 30% of the patients at the end of the treatment. And many of 31% patient might be frequently relapsing, 40% may be infrequent relapser. Some of the patients may become steroid non-responder. The good thing is that the only few percentage of the patients reach to end-stage kidney disease. So coming to this, you can see here there are 3 photographs of the patients. All 3 children have similar phenotype of the nephrotic syndrome, but when we look at the genotype, that were different and the patient has been treated differently. So coming to the case first, nephrotic syndrome child, steroid responsive initially in 2003, remained in remission for 3 years, relapsed in 2007, started on steroid but no response this time. Cyclophosphamide has been given for 2 months, kidney biopsy has been done. The patient has turned out to be focal segmental glomerulosclerosis, and subsequently the patient has been treated with the cyclosporine for almost more than a year time with AC inhibitor. Partial remission achieved. Urine protein was 2+, serum albumin was 3.5 gram, and in view of some declining renal function and due to cosmetic side effects that is very usual in the practice after starting cyclosporine, the cyclosporine was stopped. He remained in partial remission with the AC inhibitor on low dose of the steroid for 6 years so approximately. In February 2007, he had severe relapse with proteinuria. Serum albumin came down to 2.5 gram per deciliter. He has been treated with the 4 doses of rituximab, monitored CD19 count, achieved 0 cell count, but showed only partial remission. Albumin a little bit increased from 2.5 to 3.5 grams per deciliter. The patient has been caught in 2017. He came to us at SGPJ. He has episodes of very abnormal behavior, weakness of all 4 limbs and altered sensorium. The patient traveled from Bihar to SGPJ. We have got the MRI done. MRI was suggestive of acute demyelinating syndrome, and patient has been immediately treated with the 4 doses of methylprednisolone, and patient improved a lot with little residual damage of the vision. He was in partial remission with a serum creatinine value of 1.7 to 1.9 up to December 2019, and after that he has been caught in COVID and he could not turn out for 2 years. When he came back to us in 2021, he developed end-stage kidney disease, hence initiated on maintenance hemodialysis. He was worked up for living donor transplantation. His father was the donor. With induction therapy of the antithymocyte globulins, patient has been successfully transplanted and he has been discharged from our kidney transplant unit. The second case we can see is 7-year-old boy with nephrotic syndrome. So partial response to multiple courses of steroid, achieved plus minus partial remission. Kidney biopsy was done, light microscopy was showing minimal change disease, IF was negative. Electron microscopy was not done, this biopsy has been done outside. Cyclophosphamide was added with steroid and developed, but patient developed leukopenia and thrombocytopenia. That is very common with this 3-month therapy of cyclophosphamide. When you look at the search for what are the different options for the therapy for this group of the patient, levamisole, cyclophosphamide, mycophenolate mofetil, CNI, and amongst the CNI, tacrolimus versus mycophenolate mofetil. Mycophenolate mofetil versus cyclosporine, when we look at the crossover design of the one of the study, what they have shown, usually MFF inferior to cyclosporine, but when you get this adequate AUC of mycophenolate acid, mycophenolic acid, then the response rate is similar. And tacrolimus is looking like relatively better than mycophenolate mofetil and cyclosporine that I will show you. We have in early 2004, we have done pulse cyclophosphamide therapy for this group of the patient, and we have successfully demonstrated these patients had relatively less toxicity as compared to the patient on the oral cyclophosphamide. So this child was added on tacrolimus with steroid. What to do next then? And there was no response at all. So we have thought that we should go for the genetic testing, and what we have got, NUP107, that is a very uncommon genetic mutation, but reported in the literatures that can have the steroid-assisted nephrotic syndrome. So this patient can be avoided with steroid, repeated courses of the steroid. Case scenario 3. Here we can see 3-year-old female child, edematous illness. Again, started on this course of the treatment of the 2 milligram per kilogram of the steroid for the 6 weeks. And what we have reassessed at 4 weeks, edema was persistent, proteinuria was 2+, serum albumin was still low. So as per definition, we can go for, although varying, there someone takes 6 weeks of therapy, someone takes 4 weeks, but for all practical purposes, 4 weeks is standard. So what to do next now? So this patient has been biopsied. Biopsy was showing again minimal change disease, no response to steroid, and we can see the biopsy report was showing the minimal change disease. So what to do next? Genetic analysis when we have done, no pathogenic variant in the genes responsible for steroid-assisted nephrotic syndrome has been reported. So then now what to do? So what we have done, initially many patients respond to the extended course of the steroid. But at that point of the time, one of my PhD was working, and we have got the PGP expression on the lymphocytes, and that expression on the flow cytometry was 11%. So This is the one pump which efflux out the drugs from inside cells to the outside. There is no drug available to action on the receptors. So what we have tried to do, we have given this tacrolimus was added, and the patient achieved partial remission at 3 months and complete remission at 6 months. So this was the one new way to add on the therapy, particularly when you have the difficult cases. And PG expression on the lymphocyte declined to 1.9% at 6 months. So this was the one, despite common monogenic resistance, what we see, we might have the pharmacogenomic aspects of the steroid resistance. So what is the difference in the steroid sensitivity in the same disease? Why some patients respond to higher immunosuppression? We have 3 scenarios, as Dr. Anil Vasudevan has already spoken to us. You might have the alteration in the podocyte structure and function. Non-genetic mechanisms could be there of the steroid resistance or poor response, or some genetic mechanisms. In case 1, what we have seen, there was transformation from minimal change disease to FSGS. You might have the permanent damage to the podocytes due to repeated injury because of the so-called circulating permeability factors, and there is no podocytes. There might be podocytopenia, there might be the permanent injury in the form of the fibrosis or sclerosis of the podocyte, and there is no cells to act on. So that was the case 1. In case 2, we have seen new gene mutation, and that was the reason of the steroid resistance. Third is the more important. In third cases, what was the reason why he has responded to increasing dose of the immunosuppression? So what are the things which can, is there any biomarkers to detect whether this patient is likely to develop to a steroid resistant or in FSGS, MCD patients into FSGS? One study has shown IgM nephropathy, 50% chances that on repeat biopsy patient may develop FSGS, or one of the biomarker like PAX8 positive cells. If this is, it is epithelial cell biomarkers. If it is positive, then also the chances of progression to FSGS is high. What is more important for all of us, for the clinician, what we can see? Monogenic causes steroid resistance, it is very certain, but you can see in this study what we have been seeing, 25% of the patient has responded to increased immunosuppression. If you are adding on, this patient was all patient steroid resistant, but when we have increased the dose of the immunosuppression, particularly the CNI, the patient have responded, 25% patient has at least responded, and some patients of them from the monogenic cohort also responded to the treatment. That is basically about 2 to 3% or 4% maximum. So what are the evidences of the efficacy of CNI in SRNS? These studies have shown definitely it is better than placebo. When you have this active control, then it has similar effect like the CNI, tacrolimus comparing with cyclosporine. But when you have monogenic mutations, then response rate is very less. When without monogenic mutations, response rate is 68%. So we should think of not all steroid resistant patient, nephrotic syndrome patients are monogenic mutations. They are amenable for the treatment. At least in 70% of the patient, after increasing the dose of the immunosuppressions, you may get some response. We have our own study which we have followed for the long time. Patients were cyclosporine versus tacrolimus we have tried to get, and all patients were steroid plus cyclophosphamide resistant. What we have seen, tacrolimus was relatively better than cyclosporine, and patients also responded. Why do we believe the genetics play a role in the development of steroid sensitive nephrotic syndrome? Dr. Rajiv was just asking Dr. Vasudevan, is steroid sensitive nephrotic syndrome can be genetic reasons? As this is a suspicion. We have many patients who have the familiar, brother, sister, and all children are having this nephrotic syndrome. So definitely it comes in the mind. Some of ethnicity role, like the South Asian and African American descent, has a higher incidence of nephrotic syndrome than children of European descent. So when you have the genetic background, ethnicity influence, and environmental trigger, some of the patients may develop nephrotic syndrome, and these patients might be the genetic factors which is causing underlying playing role in development of nephrotic syndrome. So monogenic causes you can see only in 30% patients, and 70% patients might be immune-mediated mechanism, something non-genetic immune-mediated mechanism you're working and causing this nephrotic syndrome, steroid-assisted nephrotic syndrome initially, and who can respond to increased amount of the immunosuppressions. So Mendelian inheritance of the steroid-sensitive nephrotic syndrome, these are the 6 genes which are well documented in the literature that are associated with the steroid-sensitive nephrotic syndrome, and it has been hypothesized all these genes when comes together might have the complex interaction to each other and might have the phenotypic appearance of the nephrotic syndrome, may present as a nephrotic syndromes. And as already Anil Vasudevan has pointed out, HLA-DQ has been most studied and associated with the steroid-sensitive nephrotic syndrome particularly, and the complex inheritance. Almost 6 genes are all coming together, partially affecting each other, and it is possible that they may develop nephrotic syndrome. So here is some of the factors what we can see. Pathogenic non-self-antigen, pathogenic self-autoantigen, antigenic stimulus, HEAT1 and HEAT2. HEAT1, HLA susceptible, and HEAT2 when you are trying to modulate T cell or B cells, and then abnormal T cell functions, and the patient may develop nephrotic syndrome. So steroid-assisted nephrotic syndrome, genetic FSGS, no recurrence after renal transplantation, that is very helpful if we can test before. Immunological sporadic cases, FSGS, treatment responsive, 40 to 80% of the cases, but recurrence is high. And CNIs are usually the drug of choice. SWOT response usually in 2 months, but should be continued for a longer period of that time. Present recommendation is for at least 1 year. Previous recommendation was for 2 years. And we have experience, and there are several literature evidences, they have used up to 9 years or 10 years, and then the patient went into complete remissions. So non-genetic mechanism of steroid assistance could be there. One of the important mechanism, what we are trying to emphasize, it is possible that glucocorticoid receptors on your putative target like the lymphocytes might be less. Nuclear factor kappa beta, that is involved. So these kind of the mechanisms are also working besides your monogenic causes of steroid-assisted nephrotic syndrome. So gene associated with the steroid-assisted nephrotic syndrome, already talked by Dr. Anil Vasudevan, like coenzyme Q, you can see mitochondrial proteins. Very much now amenable to treatment, it is thought that many literatures came. If you can detect, you can supplement with the coenzyme Q and patient may get better. So from this slide, what we can see, 44% of the patient by exome sequencing, issues are not resolved. Issues remains unsolved. And there, where we have the clinician have to play a wise role by increasing the immunosuppression, looking at the response, clinical response becomes better here. So other mechanism of steroid assistance, like CNI can act, as Dr. Vasudevan has told us, on podocyte you have already calcineurin receptors. They can stabilize the cytoskeleton and can reduce the relapse, can make it steroid sensitive. And one might be the totally different mechanism disease entity like the Alport syndrome. In our series I will show you of the 68 patients, 5 patients gene turn out to be Alport's genes. So pharmacogenomic aspects, as I was talking about, the PGP. PGP is an efflux pump present on the cell's border, particularly on lymphocytes. It does not allow the steroids or any drugs to go into the cells to act on the receptors. So that's how they can cause steroid resistance. So this was the 8-year-old child developed nephrotic syndrome treated with the steroid, non-responsive at 6 weeks. PGP again showing some in the range of more than 9% of the expression of the PGP always turn out to be steroid resistance. So added tacrolimus is the substrate as well as inhibitor of the PGP. So when you add on, it inhibits the PGP, level becomes better and the patient responds. So this was the one of our study which has been published in pharmacogenomics journals, the Nature's journal, and here we can see if the expression of the PGP of more than 7% and MRP expression of more than 9%, it is possible that you can detect sensitivity and specificity of 90% and 80% that the patient is likely to develop steroid resistance in the beginning. So T cells and PGP expression during relapse and remission, this was another our study which have shown during the relapse, PGP expressions go up. As soon as this patient go into the remission, this PGP levels go down. And similarly, we can see that T regulatory cells during the remissions go up, and effector T cells like Th1 cells and Th2 cells go down. So there is a role of epigenetics also. So for that, we have what we have studied, what we have seen here. Here is the acetylation and deacetylation. Acetylation of the histone leads to opening of the two strands of the DNA. There is increased formation of the genes, particularly the pro-inflammatory genes. But when we use theophylline, which can block, which we can stimulate HDAC, then strands do not open up, and there will be no further release of different kind of the cytokines, and there would be no steroid resistance. So this makes the steroid availability better and action on the site, particularly on the receptors, a little better. And what we have demonstrated in our lab that as the PGP expression go down, HDAC expressions go up. So genetic and non-genetic steroid resistant FSGS can be there. Non-genetic, first choice is CNI. Genetic SRNS, no response to CNI. Only a few like WT1 or nephrin associated nephrotic syndrome may respond, like NHSP genes like photosyn protein can respond to some extent to some of the immunosuppressions. There is no podocyte stabilizing effect of cyclosporine. Rituximab can also have the direct action on stabilizing the cytoskeleton. Some precision medicines again comes into the role, as Dr. Anil Vasudevan has pointed out. When you have the extrarenal manifestations in this form, you can think of there is something else is playing a role, and we can investigate the patient for that syndrome. Rituximab, again, Dr. Aditi has published this paper in NEJM. At that point of the time, 2007, 5 patients, 3 patients went into complete remission. But the same group has again studied, and they shown only 70% of the patients may not respond to the rituximab if they are truly steroid-resistant nephrotic syndrome. So we have different panels here. We can see in infantile group what we have to test, in adolescent what we have to test, and these are the different genes panel that is already readily available, commercially available. We can get now. This is our SGPGMS data. We have patients of 69% we have got genetic testing. What we can see, you cannot see in the list any common genes. So NPHS1, nephrin, or these genes are not NPHS1, NPHS2, are not common, not seen in single patient. What we have seen, abnormally we have seen the uncommon genes like NUP1, NUP2, what we can see, we have seen actinin, what we have seen INF2. So uncommon genes have been reported, but common genes are not in our scenario, so we have to think of, we have to see the multicentric study. But Vasudevan has also published one genetic analysis in steroid-resistant nephrotic syndrome patients, and there also probably one patient might have the NPHS2. So it is looking like it is very uncommon mutation in Indian scenario. These are some of the drugs, and that if the patient do not respond, these are difficult to treat patients, we can think of taking this patient into the drug trials rather than going and thinking of and repeating the same kind of the drugs again and again. So novel therapies for the FSGS, what we can see, modulation of immune system and inflammation, rituximab, ACTH, abatacept, adalimumab, some antagonism of circulating factors like galactose, some antifibrotic, some stem cells, we have to think of whether the patient has the obesity or hyperfiltration related injury. That is unlikely to respond if your patient is obese. Do the biopsy, see whether this is really due to obesity or this FSGS like lesion or podocytopathy which you are seeing is related to obesity or it is related to some nephrotic syndrome kind of problems. So thank you, ladies and gentlemen. Thank you for your kind attention.
Thank you, Dr. Narayan Prasad, for your wonderful deliberation. And it was well backed up by your own researches. And definitely, I mean, we were moving from genetic to immune system disturbance, and then PGP and lot many things which we learned today. Thank you very much. And I think House will be open to questions, but before we have some comments from our chairpersons.
Thank you, Dr. Prasad, for your nice different type discussion about the different types of difficult nephrotic syndrome. We have learned from your discussion, and we also practice it, that once the child is not responding to your steroid and they have become resistant to steroid therapy, we should refer the clinician like you. And we are doing the same thing in our practice also. Thank you very much for your highlighting the different types of difficult cases of nephrotic syndrome. Thank you.
I think House is open for questions or comments, please. Quick, one or two.
Good afternoon, sir. I am Dr. Chandan, pediatrician. Very simple question, sir. If a child diagnosed at first time as a nephrotic syndrome, we started steroid. We go on for the 6-week daily treatment. When we came to alternate the therapy, after 1 or 2 weeks, suddenly started again proteinuria. Previously was protein nil, now is 1 plus, suddenly going to 2 plus. We tested for infection, there is no infection at all. What to do now? We are already on alternate therapy. The proteinuria is increasing day by day. So we should go back to 2 milligram per kg, or we should add something or continue with alternate therapy.
Yeah, this is looking like the steroid-dependent nephrotic syndrome. If during the tapering or within the 2 weeks of the stopping steroid, if the patient has a relapse, it is steroid-dependent. But you should demonstrate it on 2 occasions if the same thing happens. So then it establishes the diagnosis of steroid-dependent nephrotic syndrome. Now you have to see, there are 2 approaches. One, you can again increase the dose of the steroid, get the remission, and do on tapering. But always it has to decide by the clinician, and we have to explain the patient or patient's parents whether you want to take the toxicity of the steroid or you want to take the toxicity of other drugs. It is better to take the toxicity of other drugs rather than steroid, which is broadly thought to be the more immunosuppressive and more metabolic complications and other problems. So I will definitely like to, if it is established steroid-dependent nephrotic syndrome, we will achieve the remission, add on the cyclosporine. Presently, it's my preferred choice, but you can add on levamisole, you can add on cyclophosphamide, and then you can see whether you would be able to taper off the steroid slowly and continue the drugs, CNI, like the 1 year or 2 years of the kind.
So even if it is first episode, we can add on.
No, first episode, actually you have to demonstrate on 2 occasions, what I have told you. So this is the reason why steroid-dependent nephrotic syndrome should be demonstrated on 2 occasions.
Yeah, Dr. Vasudevan, please, take the mic.
Dependent has to be made quite consistently, otherwise we are giving a wrong diagnosis to the child. So I think if steroid sensitivity is there, although high-dose steroid dependent, they have a far better outcome than a steroid resistant. So making that diagnosis becomes very important. And the use of steroid sparing is to remove the steroids as quickly as possible, not as a substitute for a steroid. That's the other thing in the sense of steroid-sensitive nephrotic syndrome. So I think a steroid sparing can be considered after you document a steroid dependent.
Just one thing to add. Aditi, you want to go ahead? So just one thing to add to this. Children, as I tried to, I think for lack of time, I could not sort of focus on this issue, but children usually present commonly between 2 to 4 years, and the children who are presenting earlier tend to have a longer course. And if we start things like CNIs very early on, then imagine how long this child will need to be on such a drug and may even have develop a CNI dependence. CNIs we know are nephrotoxic, and therefore I think from the pediatric nephrology point of view, what we would suggest is try the other medications first. Try if you, in your patient you have a very high, you will probably have a very high steroid threshold. So in that patient, maybe levamisole may not work, but MMF, cyclophosphamide, etc. might work. In children who are relapsing with a lower steroid threshold or FRNS, you could try levamisole or long-term alternate day low-dose steroids. So we would suggest that try the other options first before starting CNIs, because we have to take them through this long course of childhood and ensure that they do not have any long-term toxicity from any of these drugs, if possible.
Seems logical. Dr. Narayan, please.
Yeah, very good, please.
Ma'am and Anil here. You know, the approaches to treating pediatric nephrotic syndrome are centered around certain assumptions that the disease is going to last about a decade. You tend to have frequent relapses early on, and then later the disease becomes infrequently relapsing. If you exhaust your options early on, you will not have anything left to do later, plus you will add on toxicities right away. The first relapse has to be treated in a standard manner. As in your child, the child has just relapsed on alternate day once. It might just be by chance. He's not doomed to be a steroid dependent. Treat the relapse, see how he does. Maybe he will not have a bad course. Let's see.
Thank you.
And there is one more question.
Yeah, please.
And because there are so many controversies, like suppose first time only we grade it as a steroid dependent, we finally document it, then is that the right time if we start, because there are different protocols. Some say that you start low dose steroid along with levamisole. Some say you start only levamisole. Some say you go for mycophenolate mofetil, because as you have told that in the beginning, because steroid toxicity also, because it has to be done in the long run. So I mean, can we have a very clear-cut protocol?
Yeah,
we have
this
that
is
in
already
the
guideline there of this Indian
guidelines in
Society of Nephrology.
2021, May 2021.
In short, just low-dose steroid with levamisole, or just low-dose steroid for the first time,
I'm
what
just,
his case is?
What I practice, I am just telling you. When I see there is no too much of the steroid toxicity, if the patient is able to maintain of the 5 milligram alternate day therapy, we try to maintain them on the 5 milligram alternate day therapy. Patients do well. You have to monitor over the growth. You have to see other metabolic complication on the child. If too much of the steroid toxicity, we don't continue steroids. Always we try to shift on. If a high dose steroid dependency is there, clinical suggestions will always be there. Use either cyclophosphamide or go for the CNI. Usually levamisole does not work too much. So levamisole, if milder low dose relapse is happening, levamisole we used to, in day-to-day practice, what I am trying to tell you. We maintain on the levamisole. If there is high dose requirement, we go on the CNI or cyclophosphamide gives for 2 to 3 months. Now cyclophosphamide is again coming back. Definitely toxic medicines. But you have to monitor. So this is the responsibility of the clinicians to do in day-to-day activities, in day-to-day practice.
How much length of time, I mean, you go for this cyclophosphamide? 4 to 8 weeks or 6 weeks?
Sir, 8 to 12 weeks are the standard. With many times, initially we used to repeat it also, but it should not be more than 150 milligram per gram body weight, total cumulative toxicity.
Right. I think final, last question please.
Sir, I am Dr. Pritpal Singh, additional professor at Univers Nephrology. Sir, my query is regarding NGS reports in patients with primary SRNS in pediatric age group. Most of the times, what our team has found that they are heterozygous and of variants of unknown significance. If they are clearly pathogenic, we stop immunosuppression or do not start it. But what is your approach or take on these patients whose report is heterozygous and not known to be pathogenic in reports and unknown significance? Sir.
So these are the few things emerging that you can know. We go on, search out the literature, see the reports, whether this was associated with any times in steroid-assisted nephrotic syndrome, what is the suggestions comes in. But definitely now there are different genes panel which are showing that this is clearly associated with these monogenic genes mutations. But as I have spoken out, it is only seen in 30% of the patient. 70% patients, it remains unresolved issue, and there you have to find out some other region of the steroid resistance, and we should work on that. We should increase the immunosuppression, see what is happening. Many patients, most of the patient responds at least 6 months of the heightened dose of the immunosuppression, particularly the CNI. If within 6 months if does not respond, even then we will suggest that you can continue for the longer period of the time. Many patients respond so long later on. But within 6 months if do not respond, chances of response becomes a little lesser.
Okay, Dr. Rajiv, last
Thank you, sir.
last question,
Sorry.
please.
Just one comment about this VUS, like don't take the report by just on the paper of it, because we have got experience that often this VUS that is reported there may be true also.
True also,
So
yeah. We have to go to a setback literature.
It is always advisable to consult a doctor who is more in like a nephrogenetic. For example, I often call Anil or have discussion with my colleagues abroad. So please don't take the report as it is.
That is just computer-based matching.
Thank you. Yes, thank you. Thank you, Dr. Narayan Prasad, and it was success of your talk that you aroused so many of questions. Thank you very much.
Dr. Aditi Sinha from New Delhi, and she would be talking about use of rituximab in childhood nephrotic syndrome, lessons learned from various trials. So we pediatricians are hardly using this molecule, so we are very eager to learn about it so that in future we can use it and take help from nephrologists like Dr. Aditi. So to chair the session, we have Dr. P.K. Rai, Senior Consultant Nephrologist at Opal Hospital, Varanasi. Dr. A. Wahid Khan, Senior Consultant Nephrologist at Brahmanand Hospital, Jamshedpur. Dr. Deepak Kumar, Senior Consultant Nephrologist at Department of Kidney and Transplantation, Medanta Jayaprabha, Patna. And Dr. Kaushal Kumar, Senior Consultant Nephrologist at Railway Super Specialty Hospital, Karvigaya, Patna. So, chairpersons to introduce the speaker first.
Good afternoon, everyone. As you all know that we are all treating nephrology, pediatric nephrology patients, and in and day out we are getting nephrotic syndrome patients. And especially those patients, we really get a lot of difficulties when the patient has got steroid resistant or steroid dependent or frequently relapsing nephrotic syndrome patients. In these situations, we really start with the steroids, we go for CNIs, we go for MMF, but in good number of patients where there is a steroid resistance or steroid frequently relapsing nephrotic syndrome patients, in these situations we have to resort to the other drugs like rituximab. Now I request Dr. Aditi Sinha, who is additional professor in Department of Pediatrics, AIIMS, New Delhi, and she has got a vast experience of treating steroid-resistant and frequently relapsing nephrotic syndrome patients with rituximab, and she is going to enlighten us with her talk on this topic, where to use rituximab in pediatric nephrotic syndrome patients. Dr. Aditi, please.
Thank you, sir. At the outset, I'd like to thank the chairpersons for introducing me to, and Professor Hemant Kumar for inviting me to this session. I am very, very grateful to you, sir, for this honor. This opportunity to teach about rituximab in pediatric nephrotic syndrome is a bit, I would say that it's a bit of a niche drug, an agent that you would use only in specific circumstances, and by no means should it mean that it should become very prevalent in its usage. This is just discussing about a drug that should rarely get used in most scenarios. So this would be the outline of my talk I would like to go through, and I would like to discuss the indications of chiefly in pediatric nephrotic syndrome, because dealing with membranous nephropathy and other adult kinds of nephrotic syndrome would not be within the purview of my talk or expertise. So B cell targeted therapies, we have heard in the last two talks how increasingly we now understand that it is not just a T cell mediated disease or just T cell dysfunction that underlies the pathophysiology of nephrotic syndrome. We now understand that also B cells have a lot to play in this. And Anil has brought out the serendipitous manner in which rituximab came to be used in nephrotic syndrome and how it was used for ITP. And increasingly people have studied and understood now that B cells do interact with T cells, and probably it is through this B cell T cell crosstalk that rituximab influences the T cell functions probably, and therefore induces long lasting remission in patients with pediatric nephrotic syndrome. Now we do know that there are a variety of agents that target T cells and B cells through their various receptors, and rituximab is but one of them. Rituximab acts on the CD20, and what it does to the CD20, if you can look at on the left side of the screen, it binds to the CD20, it gets internalized, the CD20 gets internalized, and certain pathways are activated within the B cell then, which lead to apoptosis. Now apoptosis could be due to a variety of mechanisms, and chiefly it is antibody dependent cellular cytotoxicity, but also complement dependent cytotoxicity that gets activated, leads to entirely B cell depletion from the circulation, and how this influences the T cell populations is now beginning to be understood. Now CD20 is not expressed by, say, all the cells. So the pre-B cells are not expressing it. It is being expressed in the later cell stages, and then it is not anymore expressed in the late plasma cells, etc. Therefore, theoretically, IgG production should not get impaired by use of rituximab, because late plasmablasts and plasma cells do not have CD20. However, by repeated usage, if you are going to deplete out the initial population, probably you lead to hypogammaglobulinemia. We also know now that there are a variety of other molecules that have come into play, which are, so rituximab is chimeric, and by that you see, look at the heavy and variable chains of the immune globulin and see that only 75% of it is human origin and 25% is of mouse origin, whereas there are certain humanized antibodies which we'll talk about, which are probably more safe in the sense that they might have potential of causing less side effects. So T cell binding of rituximab to the CD20 leads to B cell depletion, and we don't exactly know how this happens, but then the CD20 gets internalized, certain calcium channels and pathways are activated, and through variety of mechanisms the entire B cell population is wiped out. Now we also know that B cells are not just present in circulation, they are also present in other lymphoid organs such as lymph nodes and spleen, etc. And depending on the dosage, you may or may not be targeting those organs also, but slowly and slowly the B cells come back, both by regeneration, new population coming up, as well as by release from these reservoirs, and by 4 to 6 months usually B cells are back in circulation, and potentially the action of rituximab has gone away. The mechanisms in nephrotic syndrome are proposed to be many. We now understand that how they influence T cell populations is by increasing the T regulatory cell compartment and down-regulating the Th17 cell compartment. Now Th17 T regulatory axis has come to be understood as an important player in various autoimmune conditions and also in nephrotic syndrome, being linked to the relapse state of nephrotic syndrome, and correcting this probably leads to improvements in the state in rituximab, in nephrotic syndrome, leading to remission. We don't know exactly whether it acts on the podocyte or not. There are probably 1 or 2 papers that talk about how it binds to podocytes on the SMPDL. There are also papers that say that it might be influencing the CD80 excretion from the podocytes and so on. But all said and done, after that serendipitous exposure of that patient with ITP, which was reported in 2006, there have been a variety of experiences that have been reported all across the world, which talk about improvement in the disease state in patients with steroid sensitive nephrotic syndrome following therapy with rituximab. So administration of 1 or 2 doses of rituximab at 375 milligram per meter square during disease remission has induced remission lasting from anything from 4 to 17 months after 2 shots or 1 shot of rituximab. Other therapies could get discontinued. There was sustained remission at last follow-up in a variable proportion of patients, and usually these were from Japan, mostly 1 dose, from Europe and Asia, other parts 1 to 2 doses, and some centers have also used 3 or 4 doses. Now this was initial practice in the early 2000s, in the second decade of 2000s, and relapse rate reduction was massive. There was considerable steroid sparing. Patients could go off all other drugs. Now we we summarized all this information in our review article in the Nature Reviews in 2013 and showed that there was immense improvement in patients' steroid-sensitive nephrotic syndrome. When we looked at our own experience, which we began to use for steroid-sensitive nephrotic syndrome in 2009, and then we summarized this up to 2015 in this paper, in these two papers. We looked at two aspects. One aspect we looked at was how it compares to say a CNI, and we have demonstrated that there was comparable efficacy as compared to CNI in a small cohort of patients of about 23 patients. People have demonstrated, including us, that there is significant improvement in body habitus and improvement in height parameters. So then people have done a few randomized control trials. Now these are only a handful of randomized control trials that have looked at the response to rituximab in patients with steroid-sensitive nephrotic syndrome. The chief topic that I was given was this topic that I have to explain to you what's the evidence of the clinical trials. And these are a few of the trials that have looked at the impact of rituximab on disease course in steroid-sensitive nephrotic syndrome. Summarizing all this, a meta-analysis has been done, which I'll come to, but this was a very important randomized control trial from Japan, which really changed the game for Japan licensing for rituximab. They looked at patients with frequent relapses or steroid dependence, and they did a placebo-controlled trial in which they administered actually 4 doses of rituximab at 375 mg per meter square 1 week apart, and they, on the other side, they administered placebo. And they showed that immunosuppression could be discontinued by 4.5 months, and on a 1-year follow-up, patients did considerably better with real postponement of first relapse by several months in the patients who received rituximab versus those who received placebo. They relapsed quite early. Likewise, patients with receiving placebo required to receive other immunosuppressive agents because of treatment failure. Another RCT from this part of the country, from Kolkata, NRS Medical College, Dr. Basu demonstrated in patients with frequently relapsing steroid-sparing nephrotic syndrome, the effectiveness of rituximab vis-a-vis tacrolimus. He demonstrated that when you look at about 120 patients, 60 each allocated to tacrolimus or rituximab, patients receiving rituximab clearly did better than patients allocated to receive tacrolimus. Now, this data was published in JAMA Pediatrics, and it showed that rituximab was not only comparable, but it was probably better than tacrolimus in this group of patients. Now, there is a difference in this. This is an open label trial compared to the Japanese study, which was placebo controlled. This looked at sort of both these studies kind of used it in both firstly diagnosed frequently relapsing as well as later diagnosed frequently relapsing. So it could have been used very early on. We looked at a small study comparing the same two agents, rituximab and tacrolimus, in difficult to treat nephrotic syndrome. 20 patients each were administered either rituximab or tacrolimus quite late into disease course when they had failed at least 2 second-line agents such as cyclophosphamide, levamisole, MMF, and had evidence of significant steroid toxicity such as being very Cushingoid, having cataract, raised IOP, etc. We could show that rituximab was not inferior to tacrolimus. However, we did find that after 6 months, the effect of rituximab begins to wane off, and probably these patients require redosing, and that's why you can see that the Kaplan-Meier graph falls off beyond 6 months and patients begin to relapse. Now, this tendency to become frequently relapsing was definitely more pronounced in the patients with rituximab than tacrolimus. Now, what do we have the summary of this evidence from randomized controlled trials for steroid-sensitive nephrotic syndrome? There have been 6 randomized controlled trials so far that have been submitted by Larkins et al. In 2020, excluding the study from our center which came in later. So that was the 7th RCT. So these 6 RCTs, including a total of 269 patients with frequently relapsing or steroid-dependent nephrotic syndrome, provided moderate certainty evidence that definitely the risk of relapse was reduced by almost 80% at 6 months and by almost 40% at 1 year when patients were receiving rituximab versus, say, placebo or another therapy. And therefore, this was a very beneficial therapy. However, the meta-analysis also demonstrates a very, very high risk of infusion reactions. So you know that rituximab is a chimeric molecule. There is a risk of allergic response to it when the administration of infusion is going on. And you can make out that there is almost a 5.8 odds of getting an infusion reaction with rituximab versus getting a placebo. So clearly the risk of infusion reactions is there, for which very, very close monitoring is required, because of which it must be given in very closely monitored environments by pediatric or adult nephrologists. What about going on that topic of what after 6 months when the B cells come back and the tendency to relapse returns? What do you do afterwards to prevent relapses? So people have tried to use concomitant immunosuppression or sequential immunosuppression, that is giving say MMF or CNI or some other agent just after rituximab is given, or adding it maybe 6 months down the line. Now people have shown that there is a high proportion of patients in sustained remission when you use say MMF in this way after a single dose of rituximab, and this has been consistently an experience reported from Japan, that if they were to add on or continue to use CNI or MMF following rituximab single dose, the response is better than not adding on. But then what did we really achieve? We continued to give them plenty of immunosuppression. Probably they became even more immunosuppressed than they were before rituximab. And that's the downside to it. When we look at giving 2 doses, we seem not to require to add on any other agent. And this is what has come out in this nice, elegant study, which was an international survey of how people give therapy for frequently relapsing steroid-sensitive nephrotic syndrome with rituximab, whether they use 1 dose, 2 dose or 4 doses, and whether they add on maintenance immunosuppression or not. And this international survey looked at outcomes in relation to these things. So they have shown that if you were to use 1 dose, the time to next relapse is about 8.5 months. If you were to use 2 or 4 doses, the time to next relapse is 12 to 14 months. If you were to add maintenance immunosuppression to 1 dose of rituximab, it makes a benefit by increasing the time to relapse to 14 months. But it has no impact if you are using 2 doses or 4 doses. So that's the main message. So if you were to do 2 doses of rituximab, probably you will get away without adding on maintenance immunosuppression, versus if you were to use just 1 dose, you probably need to get some MMF or something else later in the picture to sustain that remission. Always, it's very important to look at B cell depletion afterwards. So after you give 2 doses, you look at the B cells and you expect to find less than 0.5% in circulation or less than 5 cells in circulation. And if B cell depletion is not there beyond 2 doses, you might want to give another dose, then check for B cell depletion again, and then give another dose to a maximum of 4 doses. So B cell depletion lasts for about 4 to 6 months. What afterwards? Does coming back of B cells predict relapse? Well, relapses almost invariably happen in the context of B cells having come back. But it's not as if once the B cells are back, relapse is bound to happen. The disease really varies. And some people have shown a relatedness between time to B cell repopulation and the relapse happening, some have not. Adding on therapies, as I said about MMF, there is a Japanese experience that says yes, it helps. We say that it doesn't help. One uniformly reported recent variable of interest is age at administration. So now we consistently find across publications the fact that the younger you are at administration of rituximab, the more likely you are to relapse early on. So it is better to postpone the rituximab administration to an older age, say beyond 10 years or 12.5 years, and this is coming up in all papers across the globe. Patients who have historically had steroid-resistant nephrotic syndrome course and are now turned into steroid-sensitive course are tending to have a difficult course. So do remember this algorithm. Whenever we are discussing rituximab, do understand that it remains a very, very pricey drug, no doubt, but it is something that has to be reserved for a very, very niche audience. We do not use it indiscriminately. In our algorithm, which we were discussing with Dr. Sushmita as well and in the questions, rituximab comes really at the bottom of the page. And it doesn't really come up anywhere higher. And that's because of the toxicities associated with it, as also the fact that the later you give, the better it is. So what about guidelines for when would you use it in steroid-sensitive nephrotic syndrome? We would really use it as rescue agent in patients who have failed to respond to at least 2 lines of immunosuppression and are showing features of steroid toxicity. You may use it as an alternative to steroid calcineurin inhibitors in severe steroid dependence, but always administer in remission, rule out infections, ensure B cell depletion, and only give it in a very monitored environment under nephrology supervision. What about steroid resistance? Do you use it in steroid resistance, and what impact does it have? As Dr. Narayan Prasad said, we first reported 5 patients and we found good response in them, either complete or partial response. But maybe that was just the beginner's luck. And then as we turned around to looking at more people, we began to find that it's only about 25 to 30% of kids who would turn around in a situation where you had calcineurin inhibitor resistance and steroid resistance as well. And therein only 25 to 30% would respond. And this has been the overall response rate in various series. Very often these series are an admixture of patients. You might have steroid resistance, but now with CNI use, you have become CNI dependent and steroid dependent. You are no more refractory to therapies. that patient will respond better than a patient who has not responded to CNI as well as to steroids. So that admixture has contaminated this response rate to become 45% in the early reports, versus now when we begin to see it in cleaner cohorts of patients who are just steroids resistant but also CNI resistant, therein the response rate is rather low at 27% in our work published in 2015. And then again, we look at this randomized control trial from Italy, 31 patients, really no change in proteinuria when you compare rituximab plus CNI plus prednisone on one side to CNI plus prednisone on other side. And if you were to summarize all the evidence as we did in 2013 review in Nature Reviews Nephrology, as also CME et al. Did for 2018 in pediatric nephrology, overall the rates of remission in reported literature is 50% with half and half of complete and partial remission. But as I said, this might be an admixture of patients who had responded to CNI but were historically steroid resistant. Overall, non-response predicted progression, and therefore it's worth trying out rituximab in a context of CNI resistance. We also found that late resistance is better responsive than is initial resistance, and probably that's because of contamination by monogenic disease which will not respond to immunosuppression in the initial resistance, which is not contaminating the population of patients with late steroid resistance. Overall, this is the most recent data set emerging from again an international collaborative effort of 29 centers across the globe, 246 children. So Eugene Chan as well as Gel Talus as well as several units across the world have looked at 246 children together, and this abstract is just being prepared for ESPN, and the rates of remission are still at around 32-33%. 42% at 6 months, and patients who had late resistance do better than patients with initial resistance. If you were in partial remission already at time of rituximab administration, you would do better than if you were in non-response state at rituximab administration. Obviously, it's worth trying out because people who don't respond will really go on to have kidney failure. So we look at our experience now in a third domain. Steroid resistance, given a CNI, became steroid sensitive but is now relapsing while on CNI and steroids. That is steroid sensitive relapses. So this is CNI and steroid dependent nephrotic syndrome. When we look at that patient population, something like steroid sensitive disease but a tougher group, and they tend to relapse very early on. They do respond to rituximab, but they probably require more support such as a maintenance immunosuppression or more doses of rituximab. So now we are looking at this randomized control trial which has recently been funded only this year by DHR, and with support from pharmaceutical companies as well. We have funding to randomize 160 patients to switching to therapy from CNI because you are relapsing while on CNI and time duration on CNI is already 2 years. You want to get off the CNI, but you can't because the disease is relapsing still. So you try out either rituximab or MMF, and this RCT is on way and probably will have better answers 3 years down the line. So overall, in therapy for SRNS in KDIGO guidelines, CNI remains the mainstay of therapy for steroid resistance. We would assess response, give up after 6 months, think about alternative arrangements such as rituximab, but beyond 2 years of CNI therapy, begin to discuss other options of switch such as MMF or rituximab and or discontinuing CNI. So rituximab does find a place in that set of patients. So this is again another algorithm. When you have no response to CNI, 30% cases may not respond to CNI and steroid resistance. Therein look for genetic causes. If you don't have a genetic cause, consider a therapy add-on such as MMF or rituximab. Likewise, if you are responsive to CNI, but you have had a long time on CNI, you want to get off the CNI because of toxicity or prolonged use, but continuing to relapse, consider use of rituximab. What about redosing and sequential therapy? What is the data on that? Because we know B cells come back, the disease comes back. What do you do then? So there have been attempts at looking at sequential therapy in 3 different manners, either at the occurrence of the next relapse, or at the recurrence of frequent relapses, or the moment B cells come back. These are the 3 strategies that have been in place. People have shown it in adults that it is safe to use sequential redosing at 6 months and you get away. I'm sorry, I'll just need 3 more minutes, please. So, but this sequential administration, when we have looked at our own data set, we have found good use of this practice in patients with the most difficult kind of nephrotic syndrome. Among the steroid sensitive disease, those who have failed 2 or more lines of therapy plus minus a CNI, and in resistant patients who have really been having a difficult course even while on a CNI. And therein we have looked at 250 patients, and we have demonstrated good sustained remission for almost 3 years in steroid sensitive disease and 2 years in steroid resistance disease when you're using sequential therapy for 2 to 3 years. Frequent relapses do occur in a small proportion, but it's only at about 10 to 25%. The concern with such sequential therapy is the risks of persistent severe immunosuppression, the topmost of which is hypogammaglobulinemia. As I said, plasma cells do not bear CD20, but then the B cells that form into plasma cells do have CD20, and consistently removing the B cell fraction might have an impact. Secondly, rituximab is said to induce some kind of a switch change in the memory B cells such that IgG stops getting formed in a very small proportion of patients. The other concerns that emerge are latent viruses reactivation such as BK virus, viruria, or less response to vaccines. Vaccines are an important context in childhood nephrotic syndrome. Adverse events such as infusion reactions, etc., do remain a concern. So we again look at the international survey of use of repeated rituximab. This echoes findings of our own experience. Again, 346 children, relapse-free survival relapse was postponed for 10 months with one course, but with subsequent redosing, relapse was postponed further. Adverse events, chief of the list was hypogamma, noted in almost 51%. So adverse events are of few kinds: infusion reactions, low IgG levels, and non-infectious, poorly reported, very rarely reported adverse events such as lung disease or other forms of reactions. The risk of hypogammaglobulinemia is immense. This is what we have summated from all various series in nephrotic syndrome, and we find that the overall risk is somewhere around 28%, which is an immense risk, especially with repeated use. These are some less commonly reported adverse events, but very, very sinister side effects. Agranulocytosis is also reported, and the development of human anti-chimeric antibodies can result in serious serum sickness as well as non-response to rituximab. So this is about anti-rituximab antibodies. The third indication for rituximab use is recurrent FSGS. In interest of time, I'll just skip this, but recurrent FSGS is an important indication for use of rituximab in nephrotic syndrome, and this combined with plasma exchanges remains the mainstay of management of such cases. So ofatumumab, just a word on it. Humanized anti-CD20 antibodies have been promoted recently as being useful in the sense that they might have better efficacy because they bind to a different area of the CD20, or they might have less side effects because they are more humanized. Ofatumumab has been anecdotally used for rituximab resistant or patients with rituximab allergies, and you can see that in a variety of indications, all three kinds of indications, ofatumumab has been shown to be useful, inducing remission in a fair proportion of cases. But do look at the two RCTs in red. The RCTs did not really provide good evidence for its use, and ofatumumab is far out of reach of the majority of our patients because it's far more expensive than is rituximab. So this is my summary slide, and I'll stop here and take questions.
Thank you. Thanks a lot, ma'am, for a very nice, informative presentation of a very important topic. Now the house is open to receive questions. Yes, sir.
Dr. Aditi, very nice presentation of this rituximab in nephrotic syndrome. I have one or two questions. You said this could be used as instead of tacrolimus long year. I have a patient who has been followed up for a long time. For almost 4 years, patient has been 3 years on tacrolimus, steroid-dependent nephrotic syndrome in between. So question, I told the father, he said, yes, sir, if you want now. Question is, what are the strong indications for giving? Because when one person you say it's beneficial, and how many doses to give, and looking at the side effects, yes, is it good? Another question, do we need to monitor with CD19? Yes, how often? And do you believe in giving repeated doses like 375 meters square, or a low dose as we are tried in PGI in patient membranous lesion?
May I just have the last slide projected, just for sake of completing this? So, sir, our indications, I think your patient is quite a good candidate for use of rituximab because you are not able to go off tacrolimus in that patient because of a relapsing illness, and you need to go off it because of irreversible risk of nephrotoxicity to that patient because of tacrolimus. So we would promote using 2 doses of rituximab in that context. To begin with, while in disease remission, while free of infections, 375 mg per meter square is the dose that we have conventionally used, and we find that even with this dose, sir, after 4 to 6 months, the B cells do come back. So if we were to use a lower dose, which we have not tried out, or it's not backed by evidence yet that lower doses can work, they will definitely induce depletion, sir. But then there's a rituximab pharmacokinetics involved. The rituximab stays in circulation probably for longer with 375 than with 100 mg per meter square, which will kill off all the B cells that keep emerging. So that's one thing, sir. And we would probably need to redose this patient after 6 months when the B cells come back, while looking at the immune globulin, IgG, if it's normal, Sir needs a mic. If the immune globulins are low, we would be reluctant to use it again. But otherwise, redose for a couple of years for 6 monthly intervals.
No, giving 2 doses, and after 6 months, you like to give full dose of 375.
One dose, sir.
I mean, 375 milligram per. But
we have not tried out 100 mg per meter square.
like in Mentor trial and the trial, membranous, just correlating with it. How long we can go on with that?
We have not gone longer than 3 years. We have not, for risk of toxicities which are yet to be defined.
Good evening, ma'am. So, ma'am, I just wanted to have a couple of questions. One is, what is the role of doing a MAN2 test before giving rituximab? And what are the vaccinations that you give to a child before starting him on a course of rituximab?
In an ideal world, you would do both. MAN2 test, I know that, I mean, most of our kids with nephrotic syndrome would have had a MAN2 test done when they started out with steroids. So we don't really end up doing it again for lack of value also when older. We do screen for infections properly, do a chest X-ray for sure. And if they are infection free, we would go on without a MAN2 test. That's one. Second, about vaccination, hepatitis B is an important vaccine. Pneumococcal, yes, ideally. Flu shots, ideally every year. These would be things that we would practice. Problem is that patients don't end up getting, say, varicella vaccines because of the long steroid usage that they have been having. That remains a concern. Hepatitis B hyporesponsiveness will be there, whether you're giving it during high dose CNI or high dose steroids or after rituximab. So you'll have to monitor levels and ensure immunity. Flu shots is something we would recommend.
Follow-up question to the previous.